एजेंडा किसने डाला है? उन्हीं लोगों ने डाला है ना।
Namaste, sir. Siddharth, sir. Dr. Manisha.
हाँ, अच्छा डॉक्टर मनीषा। So I am जी I am Dr. Siddharth. So I welcome you, Dr. Manisha. And for the day's proceedings, we start the all important part of ventilation, that to mechanical ventilation, and Dr. Manisha is going to take the first talk, that is the terminology used in the mechanical ventilation. That is very important because there are so many players in the field and everyone has been using his own company's own policy and terminology, so we have to understand the terminology. I invite Dr. Manisha Maurya to go ahead with her talk. Thank you. Please, Dr. Manisha.
Thank you very much, sir. So should we wait till 12?
How many participants are there? 119 per minute. Enough number of participants are there. I think they should be.
We can wait for 2 minutes maybe.
2 minutes? Okay. For 2 minutes, we can allow them some time so that. Okay. The voice is very low. Could you increase the volume? Because my volume is already high.
Mine is also 100%, sir. Are you hearing me, sir?
Yeah. Yeah, I am definitely, and your voice is quite clear.
And maybe it's from their side, sir.
Maybe.
Because you are also very clear.
Yeah, Dr. Suyog, if you are listening to me, or Neeraj ji, if you are listening to me, there is a complaint that the voice volume is quite low, so please see into the matter. Meanwhile, we are waiting for some more participants to join. There are 131, they are increasing by the second. So Dr. Manisha Maurya is starting an all important topic, basic terminology. We should understand the basics to go ahead into the details. Dr. Manisha.
Thank you very much, sir. I think
you are most welcome.
Is my screen visible, sir?
Yes, it's visible and voice is clear.
Okay, sir. Thank you. Today's basic talks will be based on the invasive ventilation, as is said by Dr. Siddharth Kumar, sir. And I'm going to take the basic terminology of invasive ventilation. There are, I think, 142 participants, and it's 1 minute left. I think I will wait for 1 minute, 12 o'clock to occur. So we all know that yesterday we learned about non-invasive ventilation. Whenever non-invasive ventilation has failed, or the patient is very much hypoxic, the patient efforts of breathing are low, the patient has poor effort, we have to start with the invasive ventilation. So for invasive ventilation, we should know some basic terminology which we set usually on our ventilators. So now I will be talking about the basic terminology. So the specific learning points are the concepts based on the basic parameters of mechanical ventilation, the parameters that control oxygenation, the parameters that control ventilation, video demonstration of how to set up a ventilator. Now let us see one by one. First is the respiratory rate or the frequency which we set on the ventilator. What is respiratory rate? Is the number of breaths the ventilator will deliver per minute. So the number of breaths either ventilator will deliver or will assist the patient breath, we have to set it on a respiratory rate, and it is the initial rate which is set is according to the physiological rate for that age. Yeah, I think in day one we learned what is the physiological rate of children. Usually children have a higher physiological respiratory rate, as we know that in newborns physiological respiratory rate may be around 40, and in infants it may be around 25 to 30. For 5-year-old up to 5-year-old child, maybe 25 to 30, and in older children, it may be around 20. So when a child lower the age of the child, higher is the physiological rate, and that has to be kept in mind while setting the initial rate. And the respiratory rate determines the minute ventilation, thus it determines the carbon dioxide elimination. So titration of respiratory rate has to be done according to the PaCO2 level, that is partial pressure of carbon dioxide, which we determine in the arterial blood gas analysis we learned yesterday. So whenever PaCO2 level is very high, going beyond the permissive hypercapnia, and it is causing respiratory acidosis, and pH is going below 7.2, then we have to increase our respiratory rate so as to have a eucapnic ventilation. So intention is to provide a eucapnic ventilation. Now next terminology is the tidal volume. Tidal volume is the volume of air delivered to the patient during a ventilatory breath. It is usually preset in a volume control modes. We will be learning about the modes in the next section. And it's variable in the pressure control mode, as we don't set tidal volume in pressure control mode, we set only the pressure. And the tidal volume is variable according to the lung compliance and the airway resistance. The initial tidal volume which we set is around 6 to 8 ml per kg. And in ARDS, we usually keep at a lower side, that is 6 ml per kg. And tidal volume also determines the minute ventilation, as the minute ventilation is the product of tidal volume and respiratory rate. The next one is the FiO2. FiO2 is the fraction of oxygen that is inspired in an air gas mixture. Usually we don't give 100% oxygen. The FiO2 which we set on a ventilator ranges from 21 to 100%, and high FiO2 should always be avoided. So FiO2 more than 60% should be avoided, as it may cause oxygen related toxicity. Initially, we can start with 100%, but as the condition of the patient improves, we have to titrate the other parameters and try to decrease the FiO2 when the child's condition improves. FiO2 usually improves the oxygenation status, and its value is adjusted so as to keep the partial pressure of oxygen in the ABG and SpO2 in the acceptable range. That is around SpO2 if we are seeing 92 to 94%, and PaO2 if we are seeing it should be around more than 60%. Now let us see PEEP. PEEP is the most important parameters which we set on the ventilator. PEEP is positive pressure that is maintained at the end of expiration. So the main function of PEEP is it improves ventilation, perfusion matching and oxygenation by decreasing the intrapulmonary shunt. So let us, what is intrapulmonary shunt? Intrapulmonary shunt is the amount of blood that is coming from the heart and it goes to the heart unoxygenated. Whenever the intrapulmonary shunt increases, oxygenation decreases. So PEEP improves the decreases the intrapulmonary shunting by improving the ventilation perfusion matching, and thus it increases the oxygenation. PEEP also increases the functional residual capacity. What is functional residual capacity? Functional residual capacity is the amount of air that is left after normal exhalation. So there has to be some amount of air left in the lungs after normal exhalation, as the alveoli may not collapse. So what PEEP does, it increases the FRC, and thus it distends the patient alveoli. It recruits the previously collapsed alveoli and thus improves the lung compliance. Now let us see this diagram. This is the first we are seeing the alveoli, in which we have kept a very low PEEP. So what does it cause? It causes the collapsing of the alveoli. So in this, perfusion is although very good, but the ventilation is not proper. In this diagram, if we are seeing an over distended alveoli, so in this we have given a very high PEEP. So what does this PEEP cause? Over distended alveoli compresses the perfusion. So in this, ventilation is good, but perfusion is poor. Anyone? Please mute yourself.
Hello, participants. Please put off all of your microphones, please.
In this diagram, we can see we have given an optimal PEEP. So both ventilation and perfusion is good. So we are seeing this example of ventilation perfusion mismatching, and this is ventilation perfusion matching, in which there is both adequate ventilation and both adequate perfusion. So PEEP causes optimizes the ventilation perfusion matching. But while setting a PEEP, we have to keep in mind, if we set a PEEP very high, it may cause over distension of lung. Over distension of lung may cause decrease in venous return to the heart, and this decreases the cardiac output, and hemodynamic instability will occur. And high PEEP may also cause air leaks in the form of pneumothorax and pneumomediastinum. So these things has to be kept in mind while setting a PEEP. The usual initial setting for setting a PEEP is 3 to 5 centimeters of water, but in ARDS we can keep as high as 8 centimeters of water in the initial setting. Now let us see peak inspiratory pressure. Peak inspiratory pressure is the highest pressure that is reached during the inspiratory phase. That is PIP. PIP improves the oxygenation of the patient. Inappropriately high PEEP may also lead to air leaks and barotrauma, as high pressure may cause bursting of the alveoli and increase sometimes in volume control mode. There may be sudden increase. We may find a sudden increase in PIP in the value setting. If we are seeing sudden increase in PIP, it may indicate the airway resistance, like there may be secretions in the AT tube or in the airway. There may be some bronchospasm or mucus plug that has to be taken care, while if we are seeing the PIP to be very high in a volume control mode. The initial setting of a PIP is usually 18 to 20 centimeters of water. Now let us see this diagram. This is a pressure time graph. We can see that PEEP, that is positive end expiratory pressure, is the pressure that is maintained throughout the cycle, and PIP is the peak pressure which is delivered in each breath. So we can see the difference. This is PIP and this is PEEP, and while giving order we should always be clear about our orders, what we are pronouncing, whether PIP or PEEP. Now let us see the P plateau. P plateau or the plateau pressure is the alveolar distending pressure, or the pressure applied by the ventilator to the small airways and the alveoli. Let us, for example, if we see the ventilator has delivered some pressure because of some airway resistance, the pressure which has reached up to the small alveoli may be somewhat decreased. So that pressure is called the P plateau pressure, and it reflects the lung compliance. It is usually kept below 30 centimeters of water. P plateau we usually don't set on a ventilator. It is derived by a inspiratory hold maneuver for about 0.5 seconds, and we get the P plateau level by doing the inspiratory hold maneuver. This inspiratory hold maneuver can be there either in the tool section or the setting section of the ventilator, in which we can do a inspiratory hold maneuver to get the P plateau levels. And in children, while setting up pressures, we should keep in mind that P plateau should not go beyond 30 centimeters of water. Now let us see P peak, and in this diagram, this is a pressure time graph. Ventilator has delivered a pressure, and because of some airway resistance, the P plateau, which is reaching up to the alveoli, is this much. Larger is the difference between the P peak and the P plateau, more is the resistance. Usually there should not be very large difference between the P peak and P plateau, and if we are finding a large difference between P peak and P plateau, then it indicates that there is some airway resistance. When we have to tackle that airway resistance, either it can be a bronchospasm, we can nebulize it, there can be secretion, we can suction it. In volume control mode, we usually don't give P peak, and if we see that in volume control mode, both P peak and P plateau are very high, it indicates the poor compliance of the lung, and that has to be kept in mind. Now let us see MAP. MAP is the mean airway pressure. Is the airway pressure in the respiratory passage during the ventilation, or it can be a area under a pressure time graph. MAP is determined by PIP, PEEP, ventilatory rate, and inspiratory time. And typical MAP is around 5 to 20 centimeters of water. We usually don't set a MAP. We derive it from various settings, or it may be in the value section of the ventilator. We can derive by the formula. For example, TI into PIP plus TE into PEEP upon TI plus TE. This is the formula of MAP. We can derive it, or we can have its value in the value section of the ventilator. We have seen that MAP is the area under the pressure time graph. This is the blue one, which is the area under the pressure time graph. So whenever we want to increase oxygenation, we can increase MAP. And for increasing MAP, we have to increase the area under the pressure time graph. So how can we increase the area under the pressure time graph? Either we can increase the flow rate, or we can increase the peak inspiratory pressure, or we can increase the TI, or we can increase the PEEP, positive and expiratory pressure, or we can increase the respiratory rate. So these are the 5 parameters on which the mean airway pressure depends upon. And mean airway pressure is the determinant of oxygen. So whenever we want to increase oxygenation, we can increase any of these parameters. The best parameter is PEEP, that is positive and expiratory pressure. Now let us see peak inspiratory flow rate, that is tidal volume upon TI, or we can say it is the maximum speed at which a set tidal volume is delivered by the ventilator. It is usually set in a volume control mode. Sometimes in volume control mode, there may not be any setting for peak inspiratory flow rate. And in that ventilator, usually the peak inspiratory flow rate is set at a default about 60 liters per minute, as it is expressed in liters per minute, and it may range from around 30 to 100 liters per minute. The higher the flow rate, faster will be the peak airway pressure reached and shorter will be the inspiration, and lower the flow rate we set, longer will be the inspiration. Now next one is the IE ratio. We usually set IE ratio is the ratio of inspiratory time is to expiratory time. So normal IE ratio is around 1:2. This ratio has to be kept in mind because we have to set a inspiratory time on a ventilator. The inspiratory time which is set on a ventilator is usually according to the physiological inspiratory time of that age. If we don't remember the physiological inspiratory time of that age, we can see the IE ratio. So whenever we are keeping the setting a inspiratory time or expiratory time, we have to try to keep the both inspiratory and expiratory time to around 1:1, 1:2. So if we if we want to remember the inspiratory time, we can see about the frequency of the physiological respiratory rate of that child. As we discussed that physiological respiratory rate of a neonate is around 30 to 40, then the inspiratory time is around 0.3 to 0.4. In infants, it is around 0.4 to 0.6, less than 5 years, 0.6 to 0.8, and more than 5 years, maybe around 0.6 to 0.8 to 0.21, and adults, it's around 1 to 1.2 or 1.4 also. So if we don't remember this inspiratory time, we just have to see the IE ratio. Sometimes we may have to increase the IE ratio, that is we can go up to 1:1, but it should be the last resort, as decreasing the expiratory time may also cause air trapping. If we want to, sometimes we want to increase the inspiratory time if we want to improve the oxygenation, as we have discussed earlier, because oxygenation depends on MAP and MAP depends on inspiratory time. So we can increase the inspiratory time to improve the oxygenation status of the patient. But while increasing the inspiratory time, it may decrease the carbon dioxide elimination and may cause air trapping and hyperinflated lungs. So this has to be kept in mind. And if we are increasing the expiratory time, it improves the ventilation. That is, it causes the carbon dioxide washout, but it may cause atelectasis, as all the air may go outside, and there has to be some air left so that atelectasis may not happen. Too less TI may lead to set tidal volume being delivered too quickly, resulting in too high pressure, and too long TI will limit the respiratory rate, resulting in hypercapnia, that is, increase in PaCO2 level. Now, let us see the phase variable upon which the basic ventilator works. The phase variables are trigger, that is this one, that is what causes inspiration to begin. Second is limit, that is what regulates the gas flow during the breath. This up to this, that is a certain variable will not go beyond that value. And C is the cycle, that is what causes breath to end and start of exhalation. So this much is the inspiration, and from here exhalation starts. So these are the various phase variables upon which a basic ventilator works. Now let us see one by one. Trigger is what determines the start of inspiration. Trigger may be of 3 types: time triggered, pressure triggered, and flow triggered. Time triggered. Time trigger is the breath delivered once a preset time has been elapsed according to the set frequency. It is usually machine triggered. It is found in controlled mandatory ventilation. So for example, if we see, if we have set a frequency of around 20 in our CMB mode, then the ventilator will deliver breath in every 3 seconds. So it is time triggered, that is machine triggered. Now second one is the pressure triggered. Pressure trigger is the ventilator senses the inspiratory effort in the form of decrease in baseline pressure. As we all know that during inspiration there is some negative pressure created in the lung, and this decrease in baseline pressure is sensed by the ventilator, and this upon sensing it assists that patient breath. Ventilator assists and gives a breath at that time. Flow triggered is ventilator senses the patient inspiratory effort in the form of decrease in flow. That is, when expiration occurs, there is decrease in flow, and at that baseline flow is sensed by the patient. And it may also sense the inspiratory flow directly from the sensor at the patient's airway opening. So flow triggered and pressure triggered, both are patient triggered, and time triggered is machine triggered. Limit is what regulates the gas flow to during the breath. That is, if a variable like pressure, flow, or volume is not allowed to rise above a preset value during an inspiratory time, it is called limit variable. For example, if we are setting in a pressure control mode, we are setting a PIP, and beyond that pressure, during the whole cycle, the pressure will not go beyond that. And for example, if we are setting up in a volume control, we are setting a tidal volume, and throughout that inspiratory time, the tidal volume will not go beyond that. So we have limited a variable beyond which the value will not go during the inspiratory time. So breath will be delivered, but variable is held at a fixed preset value. Now let us see cycle. Cycle is what ends the inspiration. So again, let us see this diagram. This is C. Cycle, what it ends the inspiration, start of exhalation. So cycle, this is a variable which is used as a feedback signal by the ventilator to end the inspiratory flow delivery, and which then allows exhalation to begin. It can be of three types: volume cycle, pressure cycle, and time cycle. Volume cycle is the inspiration ends when the preset tidal volume has been delivered. In pressure cycle, inspiration ends when a preset specific airway pressure has been achieved. And in time cycle, inspiration ends when a preset time has been lapsed. Most of the pediatric ventilators are time cycle, that is, after a particular inspiratory time, which we have said, say it may be 0.4 second, after 0.4 second, the exhalation will start and inspiration will stop. And flow trigger, that is, the ventilator senses the patient inspiratory flow and gives a breath whenever patient triggers the breath. Now, what are the practical applications of these parameters which we have learned yet? That is, either we have to increase oxygenation in the case of say pneumonia or ARDS, where the lungs are damaged and oxygenation is poor. Then we want to increase the oxygenation, and oxygenation can be seen either by PaO2 or by SpO2. And PaO2, normal PaO2, as we learned yesterday, is 80 to 100. If it is below that and oxygenation is hampering, we can increase either mean airway pressure or FiO2. And as we have discussed earlier, mean airway pressure is determined by inspiratory flow rate, PIP, PEEP, inspiratory time, and the respiratory rate. And the best parameter to increase the mean airway pressure is PEEP, that is positive and expiratory pressure. And the parameters that determine ventilation, for example, the cases of poor ventilation in which the patient is not having respiratory rate, that is, the patient is not respiring at all, either in case of apnea or in case of very CNS damage where the respiratory centers are not functioning, or in case of neuromuscular blockage like GB syndrome, the ventilation is hampered. In that case, PaCO2 levels may rise. And for that increased PaCO2 level, we have to improve ventilation to decrease the PaCO2 level. And for decreasing the PaCO2, either we can increase the tidal volume or respiratory rate. The best parameter is to increase the respiratory rate, as by increasing the tidal volume, we may also increase the pressure, and it may not be very good for the patient. We'll be seeing the videos afterward. This is a basic diagram of a ventilator. As we have seen, we have to connect the ventilator to the oxygen panel and to the air compressed air panel. In the new ventilators, we have a air compressor attached to the ventilator, and we don't have to connect the air to the air panel. There are inbuilt compressor in the ventilator, so we just have to connect to the oxygen panel. This is a ventilator, and all the three has to be the UPS, the ventilator, and the compressor. All the three has to be connected to the electric supply. If we don't connect to the electric supply, anyone is left, then we may find problems in functioning of a ventilator, and that has to be kept in mind. And then it is a breathing circuit. One is inspiratory limb and other is the expiratory limb. As we are seeing, the two limbs are there. There is a flow sensor. There is HME filter. HME filter is heat and moisture exchange filter. If we are not using a humidifier, we can use a HME filter. And HME filter which is used has to be kept according to the patient's age, as larger HME filter may cause increase in dead space. And this is a test lung. Test lung is used to see whether the ventilation is working or not. This is a basic breathing circuit. As we can see that from the ventilator patient inlet, we have connected the inspiratory limb which goes into the humidifier. If we are not keeping the humidifier, if we can use a HME filter, either of these. And then from the this humidifier, heated and humidified air goes to the inspiratory limb, and there is a water trap so that water vapors doesn't collect into the airway, these tubes which may cause airway resistance. And there is a Y piece, and through the Y piece we can connect the nebulizer if we are finding any case of bronchial asthma, or we are finding there is some bronchospasm, we can nebulize the child. So we can connect a nebulizer. It is optional, we can remove it if we don't require. And there are flow sensors. Then is a HME filter. HME filter, from that tube goes either to the non-invasive mask, that is BiPAP mask, or CPAP mask, or we can directly connect to the ET tube. From the patient expires, the expiratory limb is there, and through the expiratory limb it goes to the exhalation wall to the ventilator. So this is the basic breathing circuit. This is a basic display unit of a ventilator. As we can see, these blue squares, these are the squares in which we usually set our settings, and these are the black squares, the variables which we are determined by the ventilator, and we don't set this on a ventilator. So these are the parameters which we set on the ventilator. This is a rotatory knob by which we can just titrate the setting of all these parameters. Either we can increase or decrease. The rotatory knob is there. This is on off switch. This is alarm button. And there are graphs also: pressure time graph, flow time graph, and pressure volume graph. There are various graphs which can be seen in this, and graphs will be discussed later. These are the references of this talk. And the skills to be enhanced are: it is important to understand and set all these parameters. Changes in parameters should be done according to the patient's clinical status and arterial blood gas report. Further practical implications should be discussed in the mode sections. Initial setting and titration of these parameters would be taken in further lectures. My sincere thanks to all the contributors of this module. Thank you very much. Now I will request Mamta team to kindly display the videos of the session. Neeraj? Neeraj, are you there?
Yes, ma'am.
Please show the videos of this section.
Ma'am, which videos need to be played?
Day 3 videos, the ventilator, how to set up a ventilator.
Okay.
Yes, these one. Day 3, last 3.
Hello everyone. Today we will see about the mechanical ventilator, the parts of the ventilator, tubings, how to attach these tubing and how to start a ventilator. And the next part we'll see how to set the parameters for the pediatric patient. So this is the electronic ventilator which we are using in our ICUs. This is the main panel of the ventilator. Currently this is switched off. We have to switch on the ventilator from the back side. After connecting the charging port into the cable into the charging port, and also the humidifier, and we'll connect the cable of the humidifier the port, and we'll start the ventilator. This will see the charging cable, lights of the charging cable are on. This is the button from which we'll start the ventilator. We'll press it for the long time and we'll see the main panel is getting displayed. It will take some time to for the main screen to come. Till the meantime we'll attach the tubings. So as all the ventilator we know, we have some basic tubings. We'll take the sterile tubing, either the fresh tubing which are coming in the market or the reusable tubing which have been ETO'd or sterilized. So after donning gloves and hand washing and donning gloves, we'll take out the tubing. This part which has a 3 plug, this is the expiratory
Second video. So whenever 1 minute mute, 1 minute रुक जाइए.
These are the tubings. It has both infiltratory and exfiltratory. So how to differentiate the white.
Mamta, it's not playing smoothly. I don't know why. It's not playing smoothly.
Yeah.
Can you play it once again? It's not playing smoothly.
नीरज जी एक बार दोबारा इसको प्ले कर दीजिए. ये कुछ सुनाई नहीं दिया है.
Mamta, Neeraj, hello? Just play it once again without interruption.
So these are the tubings. It has both inspiratory and expiratory part. So how to differentiate? The one with a thin, the white tubing generally with a thin inlet is the expiratory tube, and the blue one, other one is the inspiratory tube. So as we see, this is the attachment which goes on the patient end in the endotracheal tube, and this is the end which goes into the ventilator. So we'll start with the humidifier chamber. So this is the humidification chamber, which will, as we can see, there is a line which gives us the level for the water, and only sterile water or distilled water is filled in the chamber. So this is our humidifier. We'll switch on the humidifier from this point. We'll push down the inlet and then gradually slide it down. So as a click sound has come, that means the chamber has properly fixed. Now we'll attach the tubings. So this port, this is expiratory port, and this is clearly mentioned here is expiratory. So the expiratory port will goes into this. The second part, which is the short part of the inspiratory tube. So the one part goes into the inspiration as mentioned in here, like this, and the broad part goes into the humidifier chamber. So we'll put the humidifier chamber. This is the inspiratory port which is going from ventilator to humidifier. Second part will come from humidifier to the patient end. So this is the second part of the inspiratory limb. From humidifier, the broad end will goes into the humidifier chamber, and the second part into the patient limb. For timing, we'll attach the patient limb to the test lung. There is one more tube which is oxygen tubing. This is attached from this proximal end of the ventilator up to the distal end of the expiratory limb. This is the point. Okay, so this is our tubing. Now comes the humidification. So for the how to attach the humidifier, since we have seen, we have switched on the humidifier, it is showing us the temperature. These are two modes, the invasive mode and non-invasive mode. Since we are doing the invasive ventilation, we'll select the invasive mode. And these two wires are there. So where to connect which wire? Since there are 3 ports, as you can see, we'll connect this proximal end into the inspiratory one. Like this. The second part goes into the expiratory limb here, upside. Now the second tubing, the below one, as you can see, it has a blue point and has a cone-like thing here. So this cone get attached into the inspiratory limb. As you can see, there is a conical part for this blue thing. So we'll attach it here like this. Next comes its distal part. This is conical form, and this get attached into the inspiratory limb. So our inspiratory limb is humidified and heated. Now coming to the ventilator. So after attaching to the main source, we'll attach the air and oxygen. So from behind, please come behind. So and on the back side of the ventilator, as you can see, it's clearly mentioned the oxygen port and the air port. So when we'll trace down the air port, this white port is the oxygen port. So as we'll see, this white tubing will connect into the oxygen like this. We have to plug it down and then push. Similarly, air will plug it down and push. Second thing which we will see on the back side is the flow sensor. So from here, the flow sensor wire is connected and it is then connected on the patient end like this. Now we'll start the ventilator. As we have switched on, this is the first screen which we see on the ventilator panel. We'll see the audio test. It is making sounds. Yes, we are able to hear the sound. Now here comes the second screen. Now we have to select which are we dealing with, the pediatric, like neonatal age group or pediatric age group. So if we are here dealing with the neonatal age group, less than 10 kgs, well, and it's about the flow sensor. So how to calibrate the flow sensor? So we'll take the flow sensor, we'll block both of its end or with our palm and then do the flow calibration. So as you can see, a green line has came and is saying it's calibrated. We'll go on the main screen. I will connect it back. So this is the main panel. On main panel you can see there are multiple things which is coming, and these are the modes. On baseline you can see there CPAP, nasal CPAP, dose CPAP, oxygen therapy. These are basically non-invasive modes, and the upside is control mandatory ventilation, assist ventilation, SIMV plus PSV, E-time, the frequency, this FiO2, PIP and PSV, PEEP, oxygen, and volume limit. And this is the graph we can see depending upon what parameters we are seeing, whether the pressure, volume or flow. So one by one I'll tell you what settings which we are needed to set for different parameters.
Settings will be discussed later, and so whenever Mamta, there is one more video for PM cares. Yes.
वेंटिलेटर और ये हमने
ममता?
सर्किट और टेस्ट तैयार करके रखा है।
Mamta,
मैं आपको दिखा दूं।
it's not clear. Can you replay it?
हेलो नीरज भैया,
It's
एक
not-
बार फिर से प्ले कर दीजिए।
इसको replay कर दीजिए, ये clear नहीं आ रहा है।
The patient, that is expiration, and yet to the patient, that is inspiration. ये फ्लो मीटर के लगे हुए हैं। ये very simply it attaches here and स्पायरोमेट्री के, ये यहाँ लगे हुए स्पायरोमेट्री। ये लाइन यहाँ अटैच है, यहाँ पे हमने फिल्टर अटैच कर रखा है और ये टेस्ला में अटैच है। अब मैं आपको बताऊंगा कैसे इस वेंटिलेटर को आपको ऑन करके चलाना है, यूज़ करना है एग्जैक्टली। तो इस वेंटिलेटर में आपके पास दिस इज द कंप्रेसर एंड दिस इज द यूपीएस। इन दोनों को बिजली की सप्लाई देनी है, करंट की सप्लाई देनी है, और ये है वेंटिलेटर। इन तीनों को करंट देना है हमको। वेंटिलेटर अपना करंट यूपीएस से उठाता है, तो वेंटिलेटर का जो सर्किट है वो यूपीएस पे लगा हुआ है। कंप्रेसर और यूपीएस, इनका कनेक्शन हमने यहाँ दे रखा है। ये यूपीएस के लिए है, ये कंप्रेसर के लिए है, और वेंटिलेटर की इलेक्ट्रिक करंट वो यूपीएस से आ रहा है यहाँ पे नीचे इस पॉइंट से। ठीक है, तो आपको दो आउटलेट लगाने हैं और वेंटिलेटर का इनलेट आपको यूपीएस से लेना है। अब इसको कैसे ऑन करना है? ऑन करने से पहले मैं इसे ऑफ कर देता हूँ। वेंटिलेटर बंद हो गया। ठीक है, आपने कनेक्शंस दे दिए, आपने बटन ऑन किए। आप आएंगे यहाँ पे, पहले बटन को ब्रीफली प्रेस करेंगे। पहले यहाँ से कंप्रेसर को ऑन करेंगे और यहाँ से फर्स्ट बटन को ब्रीफली प्रेस करेंगे फॉर 10 सेकेंड्स। यहाँ पे आ जाएगा वोल्टेज 230 वोल्ट्स का। वेंटिलेटर की मेन स्क्रीन पे आएंगे, यू विल कंप्रेस इट, सेल्फ टेस्ट एंड कैलिब्रेशन होगा। पास, नॉब को प्रेस करेंगे, स्टार्ट दबाएंगे, स्टैंड बाई मोड पे है। अपना मोड सेलेक्ट कर लेंगे, आप जो भी मोड यूज़ करना है आपको। सपोज आपको हमें प्रिंसिपल मोड यूज़ करना है, अपने मोड के लिए आपने स्टार्ट कर दिया और इंश्योर करना पड़ने के लिए कंफर्म कर देंगे, ये स्टार्ट है।
So while setting up of a ventilator, we have to, if we are not able to, these videos are basically for assistance. If we are not able to set up a ventilator, we can ask the technical assistance of that ventilator. They will come and they will demonstrate how to set up a ventilator. So we don't have to worry much, as these technical assistants usually come whenever we call for demonstrating how to set up a ventilator. That's all with my talk. Thank you very much.
Thank you, Dr. Manisha, for clearing us about all the basic terminology used for the mechanical ventilation to start. So we have had this basic terminology. Now another concomitant use while we are putting our patient onto the ventilator, it is mandatory to know what the ventilator will be doing to the patient. Therefore, we should monitor the patient, and some things are monitored clinically. And first, we should always have a look at the patient directly instead of the monitor. But after that, the most important part, many questions are to be answered by the monitor. What is our patient getting benefited, or is our patient still not being benefited, and we need to do some tweaking work onto the ventilator or anything else. So I invite Dr. Anupama Verma from LLRM Medical College to tell us about what the information we can get from monitor and how to use them. Dr. Anupama, please.
Good afternoon, sir. Thank you for the introduction.
You're most welcome. Please go
ahead. Good afternoon to all the panelists and all the attendees. For the next 30 to 40, we'll be talking about multi-para monitor. Sir, is my presentation visible to all?
Yes, this is biddable. Some haziness is still there. I will say request Neeraj to see why the presentations are blurred. Neeraj, please look into the matter. There is a constant complaint about, yeah, it's blurred, definitely.
Okay, sir. Let me try once more. So is this okay, better, or same issue?
I'm afraid it's similar. I think
Similar.
maybe there is something from this end. Neeraj, Mamta and company, please look into the matter. It's really blurred, and I think as the show will go on, it may be trouble, and there are continual complaints. It's very blurred. Neeraj, are you there?
Yes, sir.
ये काफी blurred आ रहा है, ये काफी लगातार complaints आ रही हैं.
Ma'am, I think there is some network connection on your side. Please check your network connection and then reshare it.
नहीं, हर जगह का आ रहा है. योर इंटरनेट कनेक्शन इज अनस्टेबल ऐसे लिख करके आ रहा है. कहीं बहुत देर से आ रहा है ये.
Sir, actually these are net issues only. That is the reason. I'll share it from my end. Just tell if it is not blurred or
Okay,
not.
okay.
आप एक
Okay,
बार
okay.
stop share कर दीजिए मैम.
Okay.
हाँ, आप जरा जी बिल्कुल.
हाँ.
No, it's the same.
It is the same.
That means it's the yeah, it's the same.
Just a second.
Quite blurred, quite blurred.
Sir, is it the same?
Yeah.
Yes.
I think last time also we had this problem. Mr. Neeraj shared from his side. Can you ask Mr. Neeraj to share?
Yeah, you share this presentation from your side.
Sure, ma'am. I'll just wait.
डॉक्टर अनुपमा, आप अपना शेयर स्टॉप कर दीजिए so that they
Yes,
can share
sir.
from their side.
Yes, sir. मेरी तरफ से stop है.
अच्छा, अभी शेड बेटर. हाँ, a little bit better, I think, a little bit better.
नहीं
Move
सर,
some
वो
slides.
सेम
Let's
ही है.
see.
सेम ही है.
Move 1 or 2 slides. Dr. Syog and Neeraj to look into the matter. Please move a slide so that we can see. Mr. Neeraj.
Ma'am, can you please try sharing the slides from your end and check the network issue? We are facing certain network issues on our side also.
It's coming. Host disabled, participants screen sharing.
Just a minute. Yeah, you can share it now.
Dr. Anupama, you can switch off your video. That may improve, maybe.
Is it
Yes.
same or
Yes. Now it is clear now. Clearer now.
it is clear?
Definitely better than before.
Better is, sir. So should I start now?
Let's see. Please go ahead. Mm, I think you will have difficulty even reading your slides.
Uh,
No, sir.
To Tapar, you're suggesting something.
I thought if she can switch off the video, at least some part.
Okay, okay. Okay,
Yeah.
sir. So should I start? It's better.
Let's see. Please go ahead.
Okay, sir. Okay. Our learning objectives for the next for next 30 to 40 minutes will be how to use different monitoring parameters. Relevant vital parameters of a sick child. In general, basic models are. Yes, sir.
I will try to listen only because the videos are really very poor. I mean, the slides are really very poor displayed. You can try to hear only. And your voice is also cracking in between.
So actually, weather is very bad today. It's raining very heavily in Meerut. Maybe
So
that will be the issue.
Answer is please go slow with your discussion so that because
Okay,
we are
sir.
not able to read the slide so that we can listen you clearly.
Okay, sir.
And
Okay,
that's-
okay, okay, sir. Okay. What is multi-para monitor? It is a simultaneous measure and display the relevant vital parameters in a sick child. In general, basic models are used to monitor electric activity, cardiac activity, ECG, heart rate, oxygen saturation, blood pressure, respiration, and temperature. It consists of 4 components, like sensor, which is attached to the body. Then there is a communication link, and then there's a processing device followed by a display, either a graphic display or a numeric display is there. Additional specifications are according to the model and maker. There are multiple brands available in the market. Rather than going to more and more advanced model, I suggest we should know our machine. That is more important. What are the monitoring domains? In cardiology, we have ECG, cardiac output, continuous cardiac output monitoring, impedance cardiography. For hemodynamic, oxygenation, and volumetric, it is invasive and non-invasive blood pressure, central venous saturation, SpO2, and perfusion index. For airway and lung mechanics, we have respiratory mechanics. For tissue perfusion, we have regional saturation. For neurology, EEG, and temperature. The red ones are the common parameters which we generally use in this multi-para monitor, and the black ones are the less used parameters. We will be talking about these red one parameters in the next slides, like ECG, respiratory rate, saturation, temperature, invasive and non-invasive blood pressure, central venous pressure, and end-tidal CO2. Other which we can have in the multi-para monitor are EEG, regional oxygen saturation, cardiac output, continuous cardiac output monitoring, central venous oxygen saturation, neuromuscular transmission, impedance cardiography, bispectral index, respiratory mechanics, and transcutaneous blood gas. First of all, we will talk about the ECG. We can use 3 lead, 5 lead, 6 lead, or 12 lead ECG. we can get heart rate either from the ECG or by the SpO2. Arrhythmia detection is very easy. Just by looking at the graph of the ECG, we can detect many arrhythmias just by at a glance of looking this waveform. And we can also diagnose many electrolyte imbalances just looking at the waves of the ECG. Whenever any patient landed in our emergency, at least we should know where to place the 3 lead electrode placement on the patient chair. 3 lead electrode placement are this. This is called LA. This is just below the left clavicle, near the left shoulder. RA is this below the right clavicle, near the right shoulder, and the LL is in the left part of the lower abdomen. तो 3 लीड है, ये सबको आने चाहिए बेसिकली कि 3 लीड से स्टार्ट, मतलब जब भी 3 लीड ये लगा देंगे तो हमारे एक वेव फॉर्म जो है वो आने लग जाएगा मॉनिटर पे और हार्ट रेट डिस्प्ले होना जाएगा. तो ये 3 पॉइंट्स हैं, ये बिल्कुल हमारे रिफ्लेक्स में होने चाहिए एक्चुअली कि कहाँ पे जैसे ही कोई पेशेंट इमरजेंसी में आता है तो 3 लीड लगा दीजिए और उस पे इलेक्ट्रोड अटैच कर दीजिए तो आपका बेसिक वेव फॉर्म आने लग जाएगा. Respiratory rate, again the same ECG leads are used to derive the impedance by this ECG are used to derive the respiratory rate. This is the graphic representation of the respiratory rate and this is a numeric value which is shown in the multipara monitor. Lead 1 which is connected to RA and LA, either this is used or RA or LL is the lead 2 is used to monitor the respiratory rate of the patient. Second is the most talk about thing in this COVID era is pulse oximetry. We get 4 things from the parameters like SpO2, perfusion index, plethysmography variability index, and signal IQ indicator. These are the pictures which show the various SpO2 the sensors available in the market. We get the clip one, we get the tape one, or this one, clip one also. So various type of sensors are available in the market for the SpO2 monitoring. We measures the oxygen saturation. Target saturation is 92. For adult, we have 94, but in children, we will be using the 92 target saturation. At the same time, we should avoid hyperoxemia, that is saturation more than 95% in newborns, which is more detrimental in newborns if we have saturation more than 95%. So for neonates, we have target 90 to 95, and for adult, we have target 92%. There is a numeric and graphic display of saturation. Probe placement should be in the right upper arm in the neonate. Avoid a limb in which the BP is being measured because intermittent inflation of the bladder causes the occlusion of the artery, which gives us the false reading, and undue attention to this false reading will be given. So we should avoid using placing sensor on the changing of probe site is also important, and ear probes are also available in the market.
Participants, please put off your microphones.
Perfusion in. Yes, sir.
I am just requesting participants to put off their microphones because disturbance is there.
Yes, sir.
Please go ahead.
Okay, sir. Next parameter we'll be talking about is perfusion index. Perfusion index is an indicator of peripheral blood flow. Periphery में कितना blood flow हो रहा है वो उसको depict करेगा. That is perfusion index. यहाँ पे आराम से एक value आ रही है. This is perfusion index. It measures the strength of the photoplethysmography signal at the sensor site. Compares the pulsatile to non-pulsatile signal and value ranges from 0.02 to 20%. 0.02 का क्या मतलब होगा कि very weak pulse strength is there. 20% का very strong pulse strength is there. Another important terminology is plethysmography variability index, which measures the change of PI during a respiratory cycle. Basically, it is used in this cardiac patient and for the volume assessment of the patient. Next important parameter is signal IQ indicator. It measures the signal. जो signal हम read कर रहा है ये sensor वो adequate है या नहीं है. मतलब basically ये sensor SIQ indicator जो monitor पे दिखेगा, basically there is a vertical line and there are horizontal lines. Each horizontal line depicts the arterial impulse. ये एक arterial impulse है, ये एक arterial impulse है. So basically regular rhythmic अगर arterial impulse आ रही है and it is measuring all, मतलब there is horizontal lines in all. This depicts the signal which is showing in the monitor is adequate, and hence the numeric value which will be showing on the monitor will be of significance. So this parameter is also important. कई बार क्या होता है कि pulse उतनी अच्छी आ नहीं रही होती है और numeric value show होती है उस पे, तो ये देखने के लिए वो जो वैल्यू आ रही है वो it is actual value of the patient or not. So for this determination, we should always in a habit to look the signal IQ indicator. Next.
Not moving.
Mamta, next slide, please.
Please move the slides.
Okay. It's moving from my side. Okay. These are the various signal indicator which are showing on the monitor. This is signal IQ indicator. This is the plethysmography. This is a regular good plethysmography which is shown on the lines are there. So this is inconclusive poor SIQ with irregular waveform, inconclusive plethysmography. In it, there is a good signal IQ indicator, and
please put on any other electronic device open near you, even the mobile phone, please.
In the last one, there is a good SIQ indicator along with the low volume plethysmography. So ideally, this graph is the ideal one, which shows a good SIQ indicator along with the good plethysmography, and this numeric value will be of significance to us. Next parameter is temperature. Temperature is thermally sensitive resistors are used. The resistance change of thermistors are used to calculate the temperature. Up to 2 temperature sites can be monitored simultaneously, and the difference between the 2 measured sites is calculated. Rectal temperature monitoring is also done with a spatial probe, but it is generally done in severe acute or in severe hypothermic patients. Next parameter is non-invasive blood pressure monitoring. This is non-invasive blood pressure is taken up by the oscillometric method based on the principle that the pulsatile blood flow through an artery creates an oscillation in arterial wave wall. So actually it gives non-invasive blood pressure gives the 3 values. एक mean blood pressure देगा, एक systolic blood pressure देगा, एक diastolic blood pressure देगा. Actual value जो measure करता है by the oscillometric amplitude, ये amplitude को read करेगा, इससे derive करता है, इससे actually measure करता है वो mean blood pressure. Systolic and diastolic blood pressure are derived from the mean blood pressure. Some important points while taking this non-invasive BP. We should determine the limb circumference first. At the midpoint is taken from the acromion process, and the midpoint we should take the limb circumference. The width of the cuff should be 40% in units, and 2/3 of the length of the upper arm should be covered. The bladder part, the inflatable portion part should cover the 60 to 80% of the arm length. Application of cuff should be such that the artery makes an appropriate place. It should be smooth and snugly fitting. And we should always choose an auto deflation mode. And ideally, average of 3 readings should be done. And we should avoid taking BP in crying or agitated child, क्योंकि unnecessary वो बड़ा हुआ BP आ सकता है. और कफ का बिल्कुल ध्यान रखना है कि वो बड़ा भी कफ नहीं होना चाहिए, छोटा भी कफ होना चाहिए to get the adequate ideal reading of the BP. These are the various disposable neonatal cuffs available in the market. अलग-अलग sizes के होते हैं depending upon this arm circumference. These are used. Second is the invasive blood pressure monitoring. It is done.
There is a request for the previous 2 slides to go again because audio quality is very poor.
Okay, sir. So this one, this. So should I start from this one?
Yes,
sir. This is non-invasive blood pressure. It is measured by the oscillometric method. based on the principle that the pulsatile blood flow through an artery creates an oscillation in the arterial wall. These are the oscillations in the arterial walls. These are read by this machine. Actually, it measures the mean arterial blood pressure. जब भी हम non-invasive से लेते हैं, 3 रीडिंग आती हैं, systolic, mean और diastolic. जो actually measure करता है by this amplitude of the oscillation is the mean blood pressure. Mean blood pressure and systolic and diastolic are derived from this mean blood pressure. So 3 values होती हैं, systolic, diastolic and mean blood pressure. Before taking the BP, we should always have these points in our mind. We should determine the limb circumference first to get the ideal size of the BP cuff. The width of the cuff should be 40% in unit and 2/3 of the length of the upper arm or thigh in the children. The inflatable portion or the bladder portion should cover the 60 to 80% of the arm length. Application of cuff should be such that the artery marking, एक artery marking होती है, that should be at the appropriate place. It should be smooth and snugly fitting. बहुत tight नहीं बांधना cuff को, बहुत ढीला नहीं बांधना. And always choose an auto deflation option. Ideally, average of 3 readings should be taken, and we should avoid taking BP in a crying or agitated child, क्योंकि false value आ सकती है, false elevated BP आ सकता है ऐसे patient. These are the various disposable neonatal cuff available in the market according to the sizes. Different sizes के available होते हैं. Second is invasive blood pressure monitoring. Invasive blood pressure monitoring is generally not routinely done. It is done in critically ill patient, real-time recording. Both numeric and wave forms can be seen in the invasive blood pressure monitoring. Here it is, actually arterial line is required to have the invasive blood pressure monitor. This is intra-arterial line attaching to the transducer. This this is a 3-way valve. This 3-way valve is connected to a transducer. Transducer is then connected to this BP cable, and BP cable is connected to this IV module, blood pressure module, and this module is fitted in this multi-para monitor. So this is the depiction of the invasive blood pressure. Along with this is the pressure bag which is filled with normal saline. This is again same pressure bag filled with normal saline attaching to the IV line. Then there is a transducer attached to it, and this is an IV cable which is a module which is fitted in the machine. This is the components of the arterial waveform. One is the systolic peak systolic blood pressure. This is dicrotic notch, and this is the diastolic blood pressure. Next domain which we will be talking about is end-tidal CO2. End-tidal CO2 capnography is a graphic display of the CO2 concentration versus time, that is time capnograph. When the CO2 concentration versus expired volume is used, it is called as volume capnograph during a respiratory cycle. Capnogram is a machine that generates a waveform, और जो actual waveform होता है उसे बोलते हैं capnogram. तो next slides में हम देखेंगे अलग-अलग capnograms कैसे होते हैं. This is this how the CO2 is produced. CO2 is the end product of the Krebs cycle produced at the cellular level, and then it is taken up by the circulation, and it is from the left side it is pumped into the right side. Hence, the ET CO2 value can also help in predicting the cardiac output. एक cardiac output कितना amplitude का वो कितना है amplitude कितना है उसका ग्राफ का. Then this CO2 is taken up by the respiration by the arterioalveolar exchange, then it comes out of the body and it's taken up by the sensor. And this is the graphic display, and this is the numeric value of the ET CO2 along with the respiratory rate of the patient. This ET CO2 sensor can be attached directly to the endotracheal tube. इसे फिर mainstream monitoring बोलते हैं, and it can be attached by an adapter, and adapter is connected to a sensor. It is called as a side stream this capnograph. तो दो तरह से है, या तो आप सीधे ET ट्यूब में कनेक्ट कर दीजिए, वो मेन स्ट्रीम आएगी, या आप साइड में बाय थ्रू एन अडेप्टर इट इज कनेक्टेड. दिस इज अ कैप्नोग्राम. बेसिकली ये इसमें दो कलर हैं, अगर ये डिफरेंशिएट हो पा रहा है तो व्हाइट कलर एंड अ येलो कलर. व्हाइट वन इज इंस्पिरेशन एंड येलो पार्ट इज एक्सपिरेशन. दिस इज अप टू दिस इज एक्सपिरेशन पार्ट. So it has different phases. First phase is, this is phase 1. This is experience.
The voice is not audible.
Phase 1. Again, this
Please
is,
repeat. Hello.
yes, ma'am. Yes, sir.
Please repeat because it was not audible.
Okay,
Please
sir.
start
Okay.
over the slide.
Okay. So I will be repeating it. Um, देखना आना चाहिए, क्योंकि इस ग्राफ को अगर बेसिकली देखने से ही बहुत सारे हम we can diagnose many things from just by looking at this graph. So it has two colors, एक white color है, एक yellow color है. White is inspiration, yellow is expiration part. ये expiration part है पूरा यहाँ पे inspiration end हुआ, यहाँ पे expiration start हुआ है, starting of expiration. This is phase 1 of the graph. Here there is a clearing of a dead space. Dead space है, so hence no CO2 is coming out of the body. Hence this is a flat graph. This is called rapid rise, and this is called as the phase 2. There is a rapid rise in CO2 as air from the alveoli containing the CO2 reaches the upper airway. अंदर वाली CO2 सारी ऊपर airway पे आ जाती है. So there is a rapid increase in the CO2. Followed by this is the phase 3. Phase 3 is called as the alveolar plateau. This is the CO2 reaches the uniform level. The height of the plateau is related to the cardiac output. एक्चुअली ये जितना हाइट होगा उतना ही कार्डिक आउटपुट पेशेंट का है. तो एक असेसमेंट भी हम ले सकते हैं पेशेंट का कार्डिक आउटपुट कितना है. बेसिकली उसमें यूज होता है जब हम सीपीआर कर रहे होते हैं, तो एक बेसिक हाइट अगर आ रही है, एम्पलीट्यूड गेन कर रहा है, तो दैट मींस वी आर डूइंग इफेक्टिव कार्डियोपल्मोनरी रिससिटेशन, चेस्ट कंप्रेशन इफेक्टिव हो रहा है. व्हाट द सेंसर read is this point. This is the end tidal end point of this. This is called as EtCO2 reading. This will be displaying in the sensor. This is the sensor EtCO2 value. This is the end tidal CO2 reading. After that, there is the end of expiration and start of inspiration, and there is a rapid decrease in the CO2. This is called as a phase 0 of the capnogram. So the inspiration begins, and there is a clearing of CO2 from the body, and as the CO2 again come out to the baseline. This is the capnogram which we see is on the monitor. These are the various abnormal capnograms. जो सीखा है कि क्या कैप्नोग्राम से अब हम इससे बहुत सारी चीजें निकाल सकते हैं. जैसे ये नॉर्मल कैप्नोग्राम है, ये भी नॉर्मल कैप्नोग्राम है, एकदम से गायब हो गया, CO2 नहीं आ रहा बॉडी से, तो हमारी क्या होगा इसमें? या तो ये देयर इज अ सडन लॉस ऑफ वेव फॉर्म, either ET tube is disconnected, dislodged or kinked. आ ही नहीं रहा CO2 बाहर बॉडी से, और देयर इज अ प्लेट्यू चला गया, उसका एम्पलीट्यूड बिल्कुल ही गायब हो गया है, तो देयर इज आइदर देयर कैन बी लॉस ऑफ सर्कुलेटरी फंक्शन. इन दिस वेव फॉर्म दिस इज नॉर्मल कैप्नोग्राम. फिर ये कम होने लगा, ये कम होने लगा और कम होने लगा, so there is decreasing EtCO2 and tidal CO2. So our diagnosis will be ET tube, either there is a leak in EtCO2 or या dysplasia है, वो hypopharynx में पड़ी हुई है या partial obstruction. Here it is, this amplitude is used for CPR assessment. तो बेसिकली अगर 10 मिलीमीटर ऑफ मर्करी का आपका एम्पलीट्यूड आ रहा है कैप्नोग्राम में, तो दैट मींस वी आर डूइंग इफेक्टिव चेस्ट pumping, chest resuscitation of the patient. Here it is, this, and then there is a rapid rise in the this CO2 of the body. So it means there is a return of spontaneous circulation. This is typical shark fin appearance seen in asthma and COPD patient. Here it is, there is a decrease in frequency which is seen in hypoventilation. Here it is increase in frequency seen in hyperventilation. Here there is normal capnogram, then there is decrease in decrease in CO2, and this is followed by a phase of apnea. So hence our diagnosis is apnea, or either the patient is heavenly. By looking at the graphic display which is there on the monitor. एक और इम्पोर्टेंट पॉइंट है कि SpO2 जो बताता है that is depicts the oxidation of the body. EtCO2 से कितना वेंटिलेशन हो रहा है. वो EtCO2 वैल्यू दिखाता है। तो अगर किसी भी वजह से पेशेंट में अगर चेंज आए, किसी वजह से उसका वेंटिलेशन पार्ट अफेक्टेड है, तो EtCO2 के जो चेंजेस आएंगे दैट इज विद इन सेकंड, बल्कि और SpO2 के जो चेंजेस आने लगे इट विल टेक टाइम, इट विल टेक सम मिनट to their fall in SpO2. So for the ventilation part, EtCO2 is the most sensitive marker rather than the SpO2.
Dr. Anupama, may I ask one question?
Yes, sir.
During CPR, so
Yes,
how
sir.
much CO2 is acceptable when ROSC is gained?
So how much CO2 is acceptable?
How much end-tidal CO2 is acceptable?
So actually for the CPR end-tidal CO2 का तो नहीं है, पर ये जो एम्पलीट्यूड है एटलीस्ट 10 मिलीमीटर मरकरी का अगर एम्पलीट्यूड अगर आपका आ रहा है, तो इसका मतलब है कि आप जो चेस्ट कंप्रेशन दे रहे हैं, मतलब जो सर्कुलेट पंपिंग है जो आपकी उसकी
when return of spontaneous circulation has occurred is indicated by some value of minimum value of EtCO2. Perhaps there is a discrepancy between the AHA guidelines and then the current technology. So AHA says 10 to 20 is acceptable for OSC, and then others say it is 25 plus minus some 10 millimeters of mercury versus some 12 plus minus 8 which are non-survivors. So that is why, for the benefit of participants, I asked.
Okay, sir. Okay.
Please go ahead. There is a lot of, I am frustrated.
Monitor.
Lot of disturbance.
Yes, sir.
Please go ahead. I mean, there is a lot of disturbance, but what we can do, we have to put up with. Please go ahead.
Okay.
We can't, you and I can't do anything about this, but.
So I'm
Please.
just feeling sorry, sir.
No, why should you feel sorry? Even I feel sorry. I am a moderator, but I can't do anything much about it. Let's see if this continues with the other speakers as well. Please go ahead. Please never.
Okay,
please
sir. Okay. Next important aspect is setting up of the alarms. We have the audio alarms and the visual alarms on the monitor. Audio, alag-alag tarike sounds are there on the monitor, and visual, there is a blinking of light. Green light aayegi, uske baad yellow light aati
Sorry,
hai.
interrupting again and again, but there is a request for repeating briefly the EtCO2 again, because most part of it was inaudible.
Okay, sir. Okay. Should I start from here only? So from the graph, normal graph, or should I start from abnormal capnogram?
Just brief from the graph, yeah. Thank you so much.
Okay. So this is the depiction of graphic display of the capnogram. It depicts this expiration part and the inspiration part. White one is the inspiration part and yellow part is the expiration part. जो येलो वाला पार्ट है वो एक्सपिरेशन, यहाँ पे आपका इंस्पिरेशन खत्म हुआ और ये एक्सपिरेशन यहाँ पे स्टार्ट हुआ. तो जैसे एक्सपिरेशन स्टार्ट होता है तो देयर इज अ क्लियरिंग ऑफ द डेड स्पेस. तो CO2 इनिशियली नहीं होता है. So this is flat one. Phase 1 is flat one. Then there is this one is the phase 2. There is a rapid rise in CO2 as the air from the alveoli reaches the upper airway, and this is the phase 3. Which is called as the alveolar plateau, and CO2 reaches the upper level, and the height also of this capnogram also depicts the cardiac output. And here it is this end of expiration, which is read by the sensor as the end tidal CO2 reading, and here it is the start of inspiration. As the inspiration begins, there is a CO2 clearing, so hence the CO2 is in the body, and this is also called as a zero phase of the cap.
So there are 4 phases of this capnogram.
Yes, sir.
Thank you.
These are the various abnormal capnograms. Here, this is normal one. Normal, no CO2 is producing from the body. Hence, either the tube is disconnected, dislodged, or kinked, or there is no this amplitude, or the other differential will be loss of circulatory function. Here it is, this is normal capnogram, and there is decrease in CO2. Decrease in CO2, either the ET tube is leak, there is leak in this ET, or either the tube is displaced, either it is in hypopharynx or there is a partial obstruction of ET tube. This is used for assessing the CPR. At least a 10 millimeter of amplitude is there. So we can assure where we are doing the effective cardiac pumping of this chest compression of the patient. There is and there is a rapid increase in the CO2 of producing from the body. So this is called as return of spontaneous circulation. This is the typical shark fin appearance, which is seen in asthma and COPD patient. Here it is, there is decrease in frequency, which depicts hypoventilation. Here it is increase in frequency, which depicts hyperventilation. And normal capnograms, decrease in CO2, more decrease in the CO2, this flat face, which depicts there is apnea, or either the patient is in sedation, followed by rapid decrease in the CO2. So various, we can inference very important information just by looking at the graphs of the capnogram. Second important aspect is setting up of the alarms. We have the audio and visual alarm. Audio, different sounds are produced, and there is visual alarms. Pehle green light blink करती है, फिर yellow and then yellow. So these should be judiciously used in our ICU setup. हार्ट रेट, रेस्पिरेटरी रेट, बीपी, जो भी पेशेंट का एज है, सेक्स है, उसके हिसाब से आपको पहले से ये मॉनिटर में फीड कर देने चाहिए. SpO2 should be again 90 to 95% in units, and target for in children will be 92. Temperature should be 36.6 to 37.6, and we can also detect, we can also set alarms in the ECG also. One important point is unnecessary alarms sounds can also be detrimental to the sick patient. So unnecessary भी use नहीं करना है कि पूरे टाइम वो अलार्म बजे जा रहा है आईसीयू में, और कई बार क्या होता है साइलेंट कर देते हैं, तो वो इम्पोर्टेंट कई बार ना इम्पोर्टेंट चीज भी मिस हो जाती है. तो वी शुड judiciously use all the alarms in our NICU. Second, last thing is using of any machine. An important aspect of using any machine is maintenance of that machine. It should be extension cable should be tucked up in a bag when not in use. Disposable accessory should be used as much as possible. Reusable accessory should be cleaned with split swab in between. An accessory when not in use should be kept in a labeled box. Key messages from my presentations are real-time monitoring of all parameters are required. We should use sensor properly because they are very sensitive. Set age-appropriate alarms for every thing, heart rate, respiratory rate, BP. Early warning of adverse changes and trends, we should diagnose, we should see it early. Response to therapeutic intervention should be done and reflect proper functioning of other equipment too. One can go through the following references if want to go in further detail. Skills to be learned are understand various parameters, identify compatible and appropriate sensor, identify and interpret abnormalities, and set alarm limits. And this is the last slide and my favorite one. The most important monitor is clinician. We should always remain vigilant, integrate monitor information into the patient care. कई बार ये होता है कि पेशेंट की रीडिंग आ रही है पर आपको अंदर से क्लिनिकल सेंस आपको बोल रहा है कि नहीं ये पेशेंट ठीक नहीं, तो वी शुड गो अकॉर्डिंग टू आवर क्लिनिकल सेंस. My sincere thanks to all the contributors and special thanks to Dr. Chandrakanta and Dr. Selyavasthi ma'am, and thank you Siddharth sir for supporting me throughout my presentation.
Thank you, Dr. Anupama. Actually, I never thought the simple monitor could give us so many informations, and really very aptly said that the monitor is the second monitor. The first monitor is all the clinicians. And
so there are 3 videos actually. If you allow me, I can play these 3 videos.
Thank you so much. Yeah, I will ask. They will show, I think. Neeraj ji, Dr. Suyog, please ये जो videos हैं ये चला दीजिए. Someone listening?
For the blood pressure monitoring of patient, we have this non-invasive blood pressure
yes, audible,
NIBP cable.
Clear.
The one end attached to the module, and the second end will attach to the disposable BP cuff. And BP cuff is available in the different size depending on the baby's age and the weight. After connecting the cable and the cuff to the baby, we will start measuring of blood pressure by pressing the knob or the touching the screen. That option is available in the monitor. And And frequency of measurement of blood pressure is can be manually, or it can be set in the according to the requirement, from varying from 5 minutes to every 2 hours, that automatically the monitor will assess the blood pressure. While the measurement of the blood pressure, the reading will be there, and ultimately at the end the blood pressure with systolic, diastolic and mean will appear on the monitor. In this baby, the blood pressure is the high range, so alarm is blinking. For the alarm setter, we touch the parameter and the separate window will pop up, and according to the gestation of and age of the patient, we can decide the low and high for each systolic, diastolic and mean blood pressure. ECG cable has also two part. One is the connecting cable, and second part that is connected to the cable and the ECG leads that have to directly attach to the baby. Usually we go for the 3-lead ECG with the left part, right part and the lower limb component that has to be attached. We can also attach to the lower left abdomen of the baby. Leads has to be attached to the baby with the electronic pads. After connecting the lead to the baby and to the monitor, there is a direct display of the ECG on the display monitor, and we can directly assess the pattern of the ECG of the baby, involving the assessment of the any electrolyte imbalance or a arrhythmia. ECG leads also give a heart rate of the baby, and in the setup we can select lower limit or upper limit of the heart rate according to the age of the baby and directly involvement and assessment of baby. Thank you. For the end tidal CO2 monitoring, we have a separate micro stream sampling line that take the sample from the exhaled air and send it to the sensor that present in the separate module. In this version 19, we have a separate module that put into the satellite unit, and the sensor is present in this module. After inserting this module into the satellite unit, we have to plug in the microstream sampling line with one end to the module and other end connected to the baby, depending upon the baby on the invasive or non-invasive mode of ventilation. For the invasive mode of ventilation, we have a hub with connector to the ET and other end to the ventilator circuit. For the non-invasive mode of ventilation, we have a nasal cannula microstream sampling line that can be used for the baby. After connecting the sampling line, EtCO2 number will display on the monitor, and then we can regulate the baby's ventilation status by assessing the end tidal CO2 more frequently with the non-invasively, and ultimately that will increase the frequency of ABG and decrease the sampling of the baby.
So that's all. We have 3 videos depicting that taking blood pressure, EtCO2, and this. That's all from my side.
So now this is the time I welcome well-known Dr. R.K. Thapar. I have heard him before. He's a very avid speaker, and we have a monitor. We have our instruments ready. We have a ventilator. But should we should we put this patient onto the ventilator? Why? Are there any indications? And if yes, how to put the patient onto the ventilator? So the indications and as well as the modes of ventilation, I welcome Dr. R.K. Thapar to present. Dr. R.K. Thapar, please.
Thank you, Kumar sir. Let me share my screen. Just a minute.
Your voice is very clear. Let's hope the
let's hope it continues to be clear. So yeah, is it visible, sir?
Yeah, thank you so much.
Great. So thank you, Kumar sir, and for giving me the opportunity, and I thank all the participants, dear friends, for continuing with this COVID training program for the pediatric population. I know it requires a lot of time management. And
I'm sorry interrupting, but I am no one to thank. It's Professor Shaili Vasti ma'am and Dr. Chandrakanta, who has done all the effort.
I'm thanking the participants who are with us for the last 3 days and will be there for next 1 day. And it is their passion that we appreciate that passion, and we are also passionate about the pediatric population. So having said that, I know that for last 2 days you have been taught about the management of how to assess a sick child, and then subsequently mild and moderate COVID. Then second day you are told about something about oxygen therapy, and then the various modes of non-invasive. So far so good. At least till the time we are non-invasively, the baby child is we are able to manage the rightful saturations and the rightful management is good. And but today you have learned something about the basic terminologies of the ventilator, and then apart from that, you have learned about the monitoring part also, that apart from the human monitoring, the machines also help us in monitoring the sick child. So having learned all those things, now let's move ahead, that we don't want that we should go ahead with the mechanical ventilation, but the condition of the child desires that the patient needs that ventilation for maintenance of saturation. So in this next 30 minutes or so, because I will not be coming in the lunch break, already 10 minutes are late. So I'll be just discussing about the indication and modes of ventilation. Regarding the particular settings, you will have Dr. Jaswant Rao in the next session or the next section, who will be further fine-tuning those settings. So let's go ahead with the indication and modes of ventilation. So the learning objective will be that why we want to ventilate, what are the indications, and to know a little bit about the causes of respiratory failure. And we will try to understand different basic modes. We'll not go into the various high-tech modes, the hybrid mode, pressure regulator, volume control. There are so many modes are coming nowadays in the most of the new ventilators. But if we stick to our basic machine, and here I would like to say that all the participants, they have to get familiarized, friendly with the equipment which they are having. Because you may have been shown ETCO2, but in your setup, it may not be available, or it is there, then it's fine. So my request will be that you all should get familiarized with your machines, whatever machines you are having, and get familiar with their settings and how to adjust with parameters. So that will be a good thing to go off, because this is a theoretical discussion. As last time somebody pointed out, we agree that this is theoretical. We just aim to refresh your memories so that you can fine tune the things better, and then understand different modes and choose the appropriate mode. That will be my learning objective. So normal respiration, basic things, that going inside of oxygen and getting rid of carbon dioxide. There's the main function of the lungs. So when we say respiratory failure, so either of the function is not performed well. That cause may be anything, but in case we are not able to maintain the oxygenation, and secondly, as has been told by my previous panelists, we are not able to maintain a carbon dioxide elimination. So basic problem with the oxygenation and ventilation, that is what we call as the respiratory failure. Now, a minute to go into the various causes, which many of you will be knowing all these things, but it will be just a refreshing that the problem may be in the higher center, the respiratory center, the brain, in the form of injury or some poisoning. Then the message from the brain, from the respiratory center, comes through a spinal cord. The problem may be in the spinal cord. Then it may be in the form of injury or myelitis. Then we all are very familiar with these syndromes of neuropathies and GB syndrome. There is a problem of involvement of the peripheral nerves leading to respiratory failure. Similarly, myasthenia gravis, toxins involving the neuromuscular junction. Then the muscle itself may get involved, which we call it as myopathies. Another common condition which we are quite familiar with is management of asthma leading to respiratory failure. The severe acute flare-ups, which the asthmatic children who are not well managed, I would say, in the present settings, present availability of management protocols by GINA guidelines, we see less of the asthma patient going into respiratory failure. This is important. This is important part because it pertains to COVID. The problem in the COVID is in the alveoli, as it is in the pneumonia, or it may be ARDS, which tomorrow you will have a lecture on management of ARDS. And so this is the problem in the present context. This is the problem, but you have to know a little bit about the other causes. Then there's a problem maybe in the cavity itself. It may be filled with the air, or it may be filled with the water, pleural effusion, tuberculosis, all those things. So these are the basic causes of respiratory failure. Now, as you have learned earlier, then we have to find, we have known that this is the failure of oxygenation and ventilation, that's respiratory failure. So how the child will present to us? He will have a lot of tachypnea, or he may have difficulty in breathing, that we call as dyspnea. There's enough use of respiratory muscles in the form of chest retractions, intercostal retractions, nasal flare. Then the patient may have cyanosis because he's not maintaining the oxygen saturation. Then initially the body tries to compensate by increasing the BP and the pulse rate, but subsequently that system also fails, leading to bradycardia and hypotension. Then clinically you will examine the chest and found some breath sounds and along with some adventitious sounds. So this is the clinical thing which we all are very familiar with, and all of you have to be masters in those clinical details. Then we have to be supported by some objective criteria. The one of the objective criteria is the low SpO2, as has been told to you by earlier speaker. So that is one of the criteria. Then the other thing, if the facility is available, then we have to go ahead with the blood gas. In the blood gas also, ABG, we just focus on these two parameters only. Let's first focus on these two parameters only as far as respiratory failure is concerned. That is PO2 and PCO2, the problem with oxygenation and the problem with the ventilation, 60 and 50. And there may be corroborative evidence. For example, if we are suspecting pneumonia, we are suspecting ARDS, so probably by that time, X-ray test must have been done. Maybe if the condition permits, a CT scan would have been. So all those things contribute to what we call, what we have been harping upon is that there's an increased work of breathing, which is the problem now. And we have to support that work of breathing. We have to lessen the burden of work of breathing. So we have learned yesterday that in case the problem is only of hypoxia, that only the patient is not able to maintain oxygen saturation. So we have got a oxygen therapy. You have learned yesterday that you can give oxygen by nasal prongs, you can give oxygen by mask, venturi mask, non-rebreathing mask. So there are HFNC, heated humidifier, high flow nasal cannula. So there are various modalities of giving oxygen when the patient is having spontaneously breathing and there is the only problem of hypoxia. Now let's see what happens if there's, along with hypoxia, now the patient is having a little raised carbon dioxide also. But so far the patient is having good spontaneous efforts. So that's a good situation. That in that situation we go for NIV, that is non-invasive. I still say that we should try to get our patients well by using non-invasive ventilation, because ventilation is a good in case of definite requirement, but it has got its own pitfalls. So non-invasive ventilation, you have learned yesterday, BiPAP, CPAP, all those things can be given. But in case now the patient has gone deteriorated further, he's not maintaining saturation and his work of breathing is more, he's having now getting tired or his respiratory efforts are poor. So this is the time that we will go for intubation and invasive ventilation. So we must have gone sequentially, increasing the oxygen support depending upon the clinical condition of the patient. Now what will be my goal? My goal is only plain and simple, that I have to improve the oxygenation and I have to get rid of the carbon dioxide. So these are my basic two goals. So oxygenation, as you must have learned in the previous lecture, is determined by the mean airway pressure, which is further dependent upon your PIP, that is the inspiratory pressure, and PEEP, that is the positive and expiratory pressure, as well as whatever time you are giving for the inspiration and whatever time you are giving for the expiration, TI and TE, plus of course FiO2 also. So these parameters will determine our oxygenation. So we have to play with these parameters, whereas for the ventilation we just have rate and the tidal volume. That rate will, that product
I
of,
think infection बढ़ गया. Your voice is also now getting
okay,
interrupted.
I have already switched off my video. Okay, so I'll try to, so oxygenation,
Okay.
better, sir? Is it better?
Let's see.
Okay, so oxygenation is determined by the mean airway pressure as well as the FiO2, whereas ventilation is determined by the rate and the tidal volume. The product which we all know is called as minute ventilation. Now let's look at the various conventional modes of ventilation. One is controlled mandatory ventilation, where everything will be controlled by the ventilator. Then there may be assist control, where the ventilator will be giving some breaths, plus it will be, patient will also be assisting those breaths. The best mode which we have been using is synchronized intermittent mandatory ventilation, what we call as SIMV. Then there's added support to that, that is what we call as a pressure support. And primarily there are two types of modes, either you are using pressure control or volume control. Both have got their ifs and buts. Both have got their positives and negatives. In neonates, we are primarily using pressure control ventilation, whereas nowadays, a lot of evidence is there as regards volume controlled ventilation. We'll see as we move ahead. So basically, a ventilator will be in the form of, this will be just like anatomy, that there's the oxygen source, which as you have been already told, and there's the air source. The air can be wall mounted air source, or it can be through the compressor, which you have been told today. And then there's a blender. Basically, blender is that equipment or that machine which we control as a FiO2, that how much air and how much oxygen we have to carry forward. Then there are inspiratory and flow transducer, and then it goes to the circuit to the lungs, and flow and pressure transducer at the expiratory valve also. So this is how a basic ventilator is. This is how the main anatomy of a ventilator. Now let's come to controlled mandatory ventilation. As the word suggests, everything is controlled by the ventilator. All parameters are controlled. Whatever you have set, the ventilator will keep on giving. Here, the patient will not have any autonomy. So patient cannot trigger the ventilator. Even if the patient is having some spontaneous breathing, it will be asynchronous, because ventilator will not give any due concern to the patient's effort. So there's the problem of asynchrony. That means the ventilator will keep on giving the breath. The patient may be in the expiratory phase. Or the ventilator may be in the expiratory phase. Patient is in the inspiratory phase. So there's a lot of problem in this mode. And that means in such a situation, if we have to use this mode, the patient has to be totally in a sedated and paralyzed situation. So you can use this mode only in apneic patients. There will be a lot of asynchrony, as I told you earlier, if the patient has spontaneous breathing. Otherwise, we have to use a lot of sedation and muscle paralysis, which has its own demerits, disadvantages of using too much of heavy sedation and muscle paralysis just for the sake of ventilation. So now, next comes assisted controlled ventilation. Now, in assisted control, if you see here, when the patient drives in some air, there's a negative pressure generated. So it triggers, there's a trigger sensitivity, we set it, so the ventilator detects now the patient is breathing. So it helps us to, that ventilator assists that breath. The patient can trigger. So there is some autonomy with the patient. Now the patient can decide, yeah, that now he has made some effort, and then the machine gives that breath. Once triggered, again, most of the parameters will be controlled by the ventilator. So it is somewhat better than the controlled mandatory ventilation. But disadvantage will be, since patient mandatory ventilator has, then the patient's possibility of hyperventilation, because every effort, whatever effort, little bit effort, if you have set the sensitivity very high, that means small effort by the patient, he just draws some air, some pressure, some volume, and the ventilator detects the trigger, gives a message to the ventilator and ventilator. So there is a possibility of hyperventilation. Again, there may be a possibility of asynchrony between various phases of the respiratory cycle. So it is little better than CMV, but it has got its own disadvantages. Now let's see what is SIMV. Now here we decide previously that we will give 40 breaths or 30 breaths depending on the age and condition of the patient. So those will be the mandatory breaths. Those will be the mandatory breaths. The patient ventilator keep on giving those mandatory breaths. In between those, the patient can have spontaneous breath. In between, the patient can have spontaneous breath. That means the fixed number of breaths will be assisted by the ventilator. The patient triggers the ventilation, ventilator assists those breaths, and then in the expiratory pause, patient can have its own breath. So this is another better than the previous two modes, that at least now the patient can trigger its own, and patient has got better autonomy. And if we reduce the ventilatory breaths, we are giving a chance to the patient to breathe. Basically, it's sort of a winning mode. But when we set the rates as a disease condition, it can act as a non-winning mode also. So these are the advantages, that patient can breathe spontaneously between the mechanical breaths. Ventilator support is tailored to the patient's demand. Facilitation of weaning, because we are giving a chance, basically we are giving a chance for the patient to breathe, so that once we reduce the, initially we may keep the respiratory rate as per the age of that patient. But gradually, once the patient starts spontaneous efforts and the efforts are good, that will be detected by the trigger sensitivity that patient is making some efforts, and we have come down on the sedation. So it will facilitate that by thereby reduction of mandatory breaths. So there will be a reduced need of sedation, and we are trying to preserve the respiratory muscles. Otherwise, if we keep on doing the ventilation only with the ventilator, so in that situation, we are not allowing the muscles to work. That may cause respiratory muscle atrophy. So we have to see, depending on the condition of the patient, maybe in the initial acute phase, we have to support, assist control. Maybe in the assist control mode, that we are supporting some breaths, but otherwise we are controlling the breaths. But as soon as the disease condition resolves or is resolving, that we come to know that his oxygen requirement is coming down, the parameters are improving. In that state, we can switch over to SIMV. So, but again, there is a problem of expiratory, though inspiratory asynchrony is not there now, but there's little bit of expiratory asynchrony is there. So that is so now what is the further improvement? The further improvement is the pressure support ventilation. That means the inspiratory breaths we have seen here, these are spontaneous breaths. So even these breaths can be supported. So that is how pressure support comes into being. Basically, the inspiratory pressure support is applied to the spontaneous breaths. Already we have decided that so many breaths, SIMV mode we are giving, 18, 20, depending on the age and the situation condition. Then we support the patient's breath also. That is the pressure support. And basically to relieve the work of breathing, and it may be used as the independent mode by itself. That we are just giving the pressure is having spontaneous breathing, but we are just supporting those breaths. And in this, the patient has autonomy. So it's a sort of a patient-triggered ventilation, PTV, what we call it as. That means we are giving more autonomy to the patient to have control over his breaths. So patient's effort exceeds the, so you have set the trigger sensitivity. If you have your machine, so there is a trigger sensitivity button. It can be a pressure sort of a thing or a flow. So not much, -1, -2, -3, -5. So basically how much negative pressure the child generates, and those negative pressure is supported by the pressure support ventilation. So this is how it can be in the form of flow also. Then the inspiratory flow is delivered to attain the target airway pressure, whatever we have set, depending on the condition, that we may have set the 20, 22, 24, depending on the condition of the patient and the age of the patient, of course. Then inspiratory flow will continue to maintain this target pressure support level as long as the patient's spontaneous effort continues. So this is a better mode as compared to the totally controlled, that is mandatory ventilation. So now let's see what happens in the pressure sport. In the pressure sport, the curves will be that patient triggers and then the pressure desired pressure, whatever we have set, is given to the patient. Then the patient triggers. So this will be the flow. That in the pressure, when the pressure rises, the flow increases. Then there's a pressure plateaus and the flow. It starts in a expiratory mode. So what happens in that? That all the breaths in the pressure sport ventilation will be initiated by the patient. Once initiated, the ventilator supports the inspiration to a prefixed whatever level you have set, pressure level, and the pressure support only as long as the patient is in the inspiratory. So there's less amount of inspiratory asynchrony. There's an advantage of, but the parameters we have to have something to set about the trigger, that you may trigger little low trigger that the patient has to make little more effort. Then gradually you have to improve that. Smaller efforts can be picked up by the ventilator. तो pressure support level आपको set करना पड़ेगा. Then PEEP, FiO2 and alarm as in other modes. So these are the two parameters which you have to set in case of pressure support. So advantages will be you are preserving the patient's spontaneous efforts. Patient has a control on all the phases of respiratory cycle, inspiratory, expiratory. It relieves the work of breathing in proportion to whatever level of support. The level of support should be more than what the patient is generating, of course. Then disadvantages maybe it can be used naturally. Patient has to breathe. In case a patient is in apnea or in a very having very large amount of work of breathing, naturally in that case we have to go for the assist control only. Then variable tidal volume and minute ventilation with the varying lung mechanics. Now see, in the initial acute phase of the illness, there will be problem in the compliance as well as the resistance. But so the pressure, whatever set we have set the pressure, depending upon the condition of the patient, it will generate some amount of volume. Because of poor compliance, the volume will not be that great. Now, as the condition improves, with the same amount of pressure, the lungs will have a more volume. Similarly, it happens in the volume control also, that if we set the volume, but because of the resistance, the pressure will be more. As the resistance improves, the pressure levels will fall. So this thing we have to keep in mind and keep on reading the various parameters on the ventilator which are depicted, that you can ventilator, they give you dynamic compliance, adynamic compliance, work of breathing. They give you so many parameters that you just have to play with the derived parameters, and then you can use and fine tune your ventilation. Now let's see main difference between pressure control and volume control. Though I must say that whatever modes you are comfortable using, please use that mode which you have been practicing. Otherwise, evidence is both in favor of pressure as well as volume control. It is your own skill and competence and your experience which matters a lot in a customized ventilation of the patients. Rule of all or none lung will not apply. So you have to keep on modifying, keep on fine-tuning the ventilation as per the patient's requirement. So in a pressure control ventilation, the pressure is delivered at a set pressure level. Set pressure level we have already fixed that we want to give 24, 26. Then the tidal volume is variable, as I mentioned earlier, depending on the lung mechanics. The flow will be like this. Understand? Now, so advantage is that since we all worried about the ventilator-induced lung injuries in the form of barotrauma, various other types of trauma. So we know that pressure is a bad thing. So we will set those pressures in a non-barotraumatic levels. That will be the advantage of pressure control. Then it do helps by MAP, that it do help in recruitment of the alveoli which are lying unopened. So it tries to open up those alveoli where circulation is already there. But the disadvantage will be the tidal volume will be different. You can't have both the things together. Some of the neural modes, hybrid modes, they try to fix that also. But those are the very high high-tech ventilators in which they are pressure regulated, volume controlled. So they are trying both the parameters. But in separately, if we see, probably we may not be able to control the tidal volume as fine-tuningly as in a volume control. Then if we have a high mean pressure, we all know that high mean pressure, whether in the form of high P, CPAP, it do have a hemodynamic dysfunction. That means it will decrease the venous return, it will decrease the cardiac output. So just keep those things also in mind if the MAP is going too high. So in a volume control, what happens is that now we have set the tidal volume. Now the fixed tidal volume will be delivered. This is how so now we are targeting the volume. The pressure may vary depending upon the lung mechanics. The pressure varies with the breath as well as the lungs mechanics. So this is a trade-off between whatever mode you want to use. If you have got access to the neural modes of ventilation, probably you can take off pressure. You can control both the pressure and the volume. But if we use separately, then we have to know this thing that pressure will vary with the breaths. So the volume control advantages will be definitely it reduces the work of breathing because you are giving adequate volume, minute ventilation, and it allows the patient to increase the minute ventilation. It can't be set below the whatever tidal volume. We know that respiratory rate into the tidal volume will be the minute ventilation. The disadvantage is that potential adverse hemodynamic effects of inappropriate hyperventilation. So it has got another trade-off that we may have to have hemodynamic effects. Then the airway pressure will vary as the changes in the lung compliance, because as the situation will improve, the airway pressures, you will keep on monitoring that. Earlier, the pressure used to be in the acute phase 20, 22, 24. I'm just giving hypothetically. Now, as the patient's condition is improving, you have already started the therapeutic measures. For example, in COVID patient, the steroids, the remdesivir, other things. And then the lung compliance has improved. So the pressure will also change now. So however, the high flow demands from the patient may not be met because you have already set the tidal volume. So these are the advantages and disadvantages of each other. Again, I request that you be comfortable in whatever mode you are using. Be confident in that mode. So this is how the tube will look like. That the airway pressure, the volume control, the alveolar pressure will gradually rise, and the flow will be slow.
Yes.
In a pressure cycle, so this will be a pressure cycle. So this is how both the curves which we see on the ventilator will look like. The graphics, the pulmonary graphics, is another science interesting to learn. So my key message is that synchronized and PTV. There is agree by use of some sedation as tomorrow. And let the patient have that much autonomy. So SIMV with pressure support. Again, the mode in which you are more confident, please use that. Please keep on monitoring the delivered parameters. If you just press the knobs, you will find many delivered parameters in many of these ventilators, and you please do set the alarms. And as my previous speaker panelist has mentioned, that alarms they give you amber colored, then red colored. So don't just ignore those alarms also. Please look after that, whether they're saying oxygen failure, it says the tidal volume is low. It keeps on giving you some ideas. It keeps on repeating those alarms. So try to listen to the ventilator also. So a lot of evidence, a lot of reading material for the people who are interested. Goldsmith ventilation book is there. Otherwise, whatever material you can catch hold of, you can read more about it. Primary objective is to refresh your knowledge and to be a helping hand. So understanding the different types of mode, hope I'm able to make it clear. Then choose a mode. We are restricted to the basic modes only. A little setting the parameters, and more setting will be told to you in the next class by Dr. Jaswant Rao. Then analyzing the displayed parameters will be a good idea. That even if you have not done it, please try to find out those. A lot of information is given by the ventilator, and then monitor the patient ventilator synchrony. That is very, very important. That they should work in unity rather than patient is having their own and ventilator, so that we don't desire. So, lot of thanks to many contributors who has made this possible, and my thanks to moderator for giving me the opportunity. It's always pleasure to work with the old friends from Lucknow, with the memories I cherish for my 5.5 years, and we have debated together on various topics also. Thank you very much.
Thank you, Dr. Thapar, and it was really enthralling and very clear slides and very good slides. But I redirect all the thanks to Professor Shalyavasti ma'am and Dr. Chandrakanta ma'am.
Surely.
And I really thank them to give me the opportunity to moderate. And now we part for lunch, and after 20 minutes, we welcome you all.
Any questions? Any questions? I'll be happy to, if there are.
So on your behalf, Dr. Thapar, there were a question, which one is better, because you have already answered. So I told them whichever they are experienced with and they would like, but in units, usually we prefer.
Yeah. So I finished at the right time so that they can, I am not coming in the lunch.
Well within time, very crisp, very, very nice. You have taught us how to make the slides and how to, manage the time.
Thank you, sir. Thank you. Nice meeting you all, sir.
Really nice meeting. Thank you so much. So
we meet at 2:10 or 2:15?
2:20.
Okay. Let's 2:20. There are 2:20 people are there on the at times. So
yeah, really, you're so really. Yeah.
Well, thank you, sir. Thank you.
Thank you. So nice of you. Thank you. Dr. Kavita, are you around?
Only.
Hello, Dr. Kavita, Meena, can you, okay, hello.
Afternoon,
I
sir.
welcome Dr. I think meanwhile, please try to share your slides so that we can say, because there was a lot of snag earlier.
Yes, sir. So my slides visible, sir?
Right now, there is a list. The slides are not there.
I've
List is
already.
there.
So it is visible now?
No,
Still not visible.
no.
So my
There's a
screen
list of your
is
presentations.
being paused. I think it has resumed share. Okay, sir. So not visible again?
No, still not.
Okay, sir, just let me do it once again.
Click on share your screen first, then click on your list and then click share again. After clicking the list, please click the share again. Yes,
Okay.
there you are. Yeah. We have around 169 participants. Let's give them 1 minute more, then we'll start. So this is dot 220 and lot of participants kindly have come back, and after the individual sumptuous perhaps lunches, we welcome Dr. Kavita Meena again from IMS BHU. And now, as we know something about the indications, the ventilator is ready, the patient is needing, but how to connect the patient and the ventilator, because there are two. One was the crude way, but non-invasive, that is the non-invasive ventilation. This is the finer way to reach into the lungs, but we have to put an invasive device. So intricate management of endotracheal intubation in children and also the airway management will be dealt with Dr. Kavita Meena. I welcome Dr. Kavita. Please
Good
enlighten.
afternoon, sir. Thank you, sir, for the introduction. In this session, we'll be discussing about endotracheal intubation in children. Our learning objectives will be understanding the key anatomical differences between pediatric and adult airway, comprehension of the equipment and preparation required for endotracheal intubation in children, procedural steps of performing endotracheal intubation. Overview of the presentations will be under indications, contraindications, anatomy, preparation, procedural steps, aftercare, potential complications, and common pitfalls. So if we talk about endotracheal intubations, then the indications for intubation are failure of oxygenation or ventilation. If the partial pressure of oxygen is less than 60 millimeters of mercury on 60% FiO2, or if the arterial partial pressure of carbon dioxide is more than 50 millimeters of mercury, so it is an indication for intubation. Or there is inability to maintain or protect his or her airway. Severe systemic conditions like hypotensive shock or cardiopulmonary resuscitation, anesthesia, procedures requiring sedation, or neuromuscular disorders. So these are the indications for intubation. There is no absolute contraindication for intubation, but there can be relative contraindication.
There is a request, Dr. Kavita, from the audience side. Please be a little loud or increase your volume.
Okay, sir. Okay, sir. So my volume is maximum. I try to be loud, sir. Okay, sir. Relative contraindications are anticipated difficult airway, difficult to intubate patient, or alternate airway or expert team. Now, if we talk about anatomy, so there is a basic difference in the anatomy of an adult and of a child. If we talk about shape of the airway, then in adult it is cylindrical. In case of children, it is funnel shaped. Tongue is not large compared to the other airway structure, but in case of pediatric patient, tongue is large compared to the other surface areas. Epiglottis in adult is shorter. It is not floppy, so it is not easily collapsible. Whereas in case of children, epiglottis is very big. It is U-shaped and it is floppy, so it collapses very easily, leading to the airway obstruction. If we talk about the narrowest point in the airway, then in adult, hyoid bone is the narrowest part, whereas in case of children, it is the cricoid ring, which is the narrowest part in case of the children. Now, airway alignment is very important before attempting for intubation. Why airway alignment is required? Because in case of pediatric patients, the head size is large compared to the other body structures, and neck is naturally flexed because the size is large, so their neck is naturally flexed, leading to the compression of the soft tissues. So, tongue that we have discussed is relatively large. So tongue keeps falling back, which leads to the airway obstruction. So before intubation, what we need to do is the airway alignment. And for intubation, the position which is there, it is called the sniffing position. So we basically have to see three endpoints. First of all, if we see at number one, then we have to see glabella and chin. They should be in one plane, and the plane should be parallel to the surface, parallel to the ground, or parallel to the bed on the which patient is lying. If we see the endpoint 2, the neck should be widely open. Initially, the neck which was compressing, it should be widely open. And if we see the point number 3, then if we the external auditory meatus of the patient should correspond to the sternal notch of the patient. So again, it should be like a straight line parallel to the ground. So these are the endpoints, and when we are placing a patient for endotracheal intubation, we should try to meet all these endpoints. And to achieve the endpoints, we can use the headrest or we can use the shoulder roll. So first of all, we should place the child on a horizontal surface. We should see all these endpoints. If these endpoints are met or not, if not, then we should place a headrest below the head of the child. And again, we should check all these three endpoints. If endpoints are met, then your position is achieved. But again, if it is not, then we should place a shoulder roll below the shoulder of the patient. And again, we should check all these endpoints. And in case of pediatric patient, usually placing a shoulder roll solves our problem, and we are able to achieve a sniffing position most of the time. So this is again showing what is the difference in the position that is required and the position in which the patient is lying. And these are again the various techniques through which the position can be achieved. If it is an infant, then shoulder roll, placing a shoulder roll, we can achieve the position. If it is a small child, then keeping the child on the flat surface and extending the airway can achieve this position. Whereas in case of older children, we can keep headrest below the head of the older child, and then we can check for the position. In these areas, we have to see the external auditory meatus of the patient and a line going through the shoulder, anterior part of the shoulder. So if we match these lines, then this line should be parallel to the ground. So these are the various techniques through which we can achieve our endpoints and we can check our endpoints. Now, once we have made the position and before attempting for intubation laryngoscopy, we should know what we are going to see. So this is the anatomical landmark, and these are the landmark we should try to identify when doing the laryngoscopy. So this is the epiglottis. Behind the epiglottis, this part is called vallecula. These are the vocal cords. This is the glottic opening. These are the array epiglottic fold, and these are the arytenoid cartilage. So the things we should aim while doing the laryngoscopy is should be this. This epiglottis, we should be able to identify our airway is always lined by this epiglottis. So that's how we can differentiate it from the esophagus. This is one part. And the other part is when we see this glottic opening, then we see these two glistening white structures. So we should able to identify these glistening white structures. So our target should be this epiglottis and these two glistening white structure. We should identify these structures. This is again the anatomical landmarks that which we are need to identify. So this is the esophagus, which is quite near to the glottic opening, but esophagus is not lined by the epiglottis, whereas the glottic opening or the airway opening is lined by the epiglottis. So we should try to identify the epiglottis of the patient. The shape of the epiglottis changes with age. So in case of newborn, it is inverted U shape. In case of child, it is triangular. In case of adult, it is circular. For after identifying the structure that we need to see, then there are certain preparations that we need to do. And for those preparations, there is a simple mnemonic with which we can remember. It is SOAP me. So before attempting for scopy and intubation, we should be ready with the suction apparatus, with the oxygen, with the airway and personal protection equipments. Suction can be wall mounted or standalone. Most important thing is the suction pressure because mucosa is very soft in case of pediatric patient. So suction pressure should be 80 to 100. Suction tube should be ready. Suction catheter size should be available, 8 to 14. Oxygen can be provided by non-rebreather mask or nasal cannula or ambu bag with reservoir or oxygen tubing. For airway, we should have appropriate size endotracheal tube, oral and nasal airway, and laryngeal mask airway, and personal protection for the person who is going to attempt the procedure and who is going to manage the patient. Then medications we should have pre-medications, paralytics, resuscitation medications like epinephrine and atropine. And in case of equipments, we should have laryngoscope, appropriate size blade, mask appropriate size, ambu bag, stilette, working IV lines, syringes, tape, towels, pads for airway alignment, stethoscope, monitor, and then end-tidal CO2 monitoring. And we should keep the ventilator after intubating the patient. In the laryngoscope, we can use two kind of laryngoscope. One is the Miller blade and other one is the Macintosh blade. Miller blade is a straighter blade and it can be used in infant and young children. So when we are using the Miller blade and we are trying to do laryngoscopy in pediatric patient, then we should directly lift the epiglottis of the patient. Why? Because as we have discussed, in case of pediatric patient, the epiglottis is large, epiglottis is floppy. So we should directly lift the epiglottis to see the glottic opening. And this blade provides better control of the tongue. Again, in pediatric patient tongue is large, so better control is required. So that's why it is indicated in pediatric patients. But if we have older children, then Macintosh blade can also be used. This Macintosh blade is curved, it is wider, and it is placed on vallecula. And in case of older children and adult, the blade tip is placed into vallecula, and then we have to lift the handle, and we don't directly lift the epiglottis through this blade. And in this blade uh, there is a place which curves around the tongue and it deviates the tongue away from the area of visualization. So this is the benefit of this laryngoscope. Now, for the sizes of laryngoscope, if we are using Miller or if we are using Macintosh, for preterm, we can use 0.0 to 0. For term, we can use 0 to 1. For infant and toddler, we can use size 1. And in case of preschool and school children, we can use Macintosh size 2 and 2 to 3. How to identify the appropriate size of endotracheal tube? So if we are using an uncuffed tube, then we can remember this formula, age in years by 4 plus 4. And if we are using a cuffed tube, then we can remember this formula, age in years by 4 plus 3. So that's how we calculate the size of endotracheal tube. And we should always be ready with a size above and a size below, so so from the calculated size. For the depth of insertion, again, we can use this formula, which is age in year by 2 plus 12, or we can roughly estimate by internal diameter of the endotracheal tube, which is uh, given on the packing of the endotracheal tube, and we can multiply that diameter into 3. So we will get approximate length in centimeters for the insertion of the endotracheal tube. And for the cuff pressure, it should be less than 20 centimeters of water. So these are the different sizes of the endotracheal tube. So if we are using an uncuffed endotracheal tube or if we are using a cuffed endotracheal tube, the inner diameter is given and the corresponding outer diameter is mentioned here. So we should have an idea about this. Then for intubation, we might need assistance in the form of hyperglutated glidoscope stillet or standard endotracheal tube stillet or elastic bougie. These are the equipments which are very helpful and we should keep ready. Sometimes we are not able to negotiate the tube, then we can pre-form the shape of the tube, and then it is very easy with these equipments to intubate the patient, because uh, endotracheal tube slides very easily if it is preformed by using these hard to stillets, or if we are not able to see the glottic opening completely, then we can only use this elastic bougie. We can first introduce the elastic bougie and then we can railroad the tube in cases of difficult intubation. So these are the adjuvant equipment, ambu bag. For neonate, the size is 200 to 300 ml. For infant and children, it is 450 to 500 ml. For adolescent and children, it is 1000 to 1500 ml. So mask size and hold, appropriate mask size. We don't have to actually remember the mask size. We can estimate the mask size by just keeping the mask on the nose and mouth of the patient. So we should keep the triangular area on the bridge of the nose and the circular area on the chin of the patient, and we should see whether it fits or not. If it is fitting well, then this is the size of mask that we should be using. It should not be very large or it should not be very small, otherwise we'll face difficulty while ventilating the patient. So this is the size of the mask. Then how do we hold the mask? So we use a C and E technique for this. So this is the C technique and this is the E technique. So it is a part of one technique, that is mask holding. So with the C, we use thumb and index finger. We just lightly press the mask on the nose and mouth of the patient. And with E technique, we try to lift the airway of the patient. So we should always keep these fingers on the bony prominences of the patient. We should never keep these fingers on the soft tissue. Otherwise, we'll suffocate the patient rather than ventilating the patient. So this is the thing that we should keep in mind. And we can use two hand technique. So two hand technique is basically the same C and E technique, but we are using both the hands to lift the airway, and we are using thumb to press the mask on the nose and mouth of the patient. So we can use any technique we are comfortable with, or we can use technique according to the personnel available around us, so that if we are alone, then this technique is better, or if we have assistance, then we can use this technique, two hand technique. Now, adjunct equipment, we need suction apparatus to remove secretions from the airway of the patient and to clear our airway. So, corresponding endotracheal size have corresponding suction catheter. So, if it is 5, then it is size 8, then 10, then 12, then 14. So, 8 to 14 size of the suction catheter should be available. And suction pressure, as we have mentioned, it should be around 80 to 120 millimeters of mercury. Now we talk about oropharyngeal airway. Again, oropharyngeal airway help us in opening the airway of the patient. So this oropharyngeal airway is called a Goodell airway, which is available in size 00 to 4, and its length is 4 to 20 centimeter. How to calculate the size, whether we are using the appropriate size of oropharyngeal airway, because some of us may not remember the size and some of us may not remember the corresponding color. So we don't have to worry in that situation. We just have to keep the airway, the proximal end of the airway at the middle part of the lip, and the distal end of the airway should be at the angle of the mandible, and this curvature should face upwards. So this is how we can estimate the size of the Goodell airway. And if we can remember the color coding, then it is very good, because the size can be remembered according to the color also. So this is how we calculate the size of Goodell's airway. The other adjunct equipment that we require are the securing tape. Once we have intubated the patient, we need to secure our endotracheal tube into position. And then we need monitoring equipment. These equipment tell us whether we have our intubation is correct or not, whether we are at place or not. So these are the two adjunct equipments that we require. And personal protection. Now, since we are dealing with COVID patients, so personal protection is very important. So we should have a, if we are dealing with a COVID patient, then we should have a PPE kit with us. For the pre-medication, we use tranquilizers like benzodiazepine, promethazine, opioids like fentanyl and morphine, non-opioid analgesics like acetaminophen, dissociative agents like ketamine, anticholinergic agents like glycopyrrolate or atropine, antacids and H2 blockers like ranitidine and metoclopramide. We can use midazolam for pre-medication, or we can use ketamine for pre-medication. We can give IV and IM. So the doses of IV and IM is mentioned here. So we can choose any route with which we want to give the drug. So we just have to keep in mind what is the dose for which route, and duration with which it acts when we use that route. For resuscitation, we should keep ready epinephrine loaded syringe, and the dilution should be made in 1 is to 10,000, and the dose is 0.01 mg per kg IV. Atropine, in case we face any kind of bradycardia, the dose is 0.02 milligram per kg. In IV fluids, normal saline should be ready. And for children, we should have calcium gluconate as well as hydrocortisone. For though we can use normal intubation for the patient, but since we talk about COVID scenario, and in COVID scenario we always go for rapid sequence intubation. So in rapid sequence intubation, we know COVID is a very pressing time, but still, if we are using a neuromuscular agent, then we should be very careful, because uh, before using these agents, we should always check ventilate the patient, because we don't want to land up into the situation where we can't ventilate the patient and where we can't intubate the patient. So COVID patient, if we are using a neuromuscular agent, or any other patient, if we are using a neuromuscular agent, we should always check ventilate the patient, and we should make sure that we are able to ventilate the patient. So just in case if we are not able to intubate the patient, at least its ventilation won't be hampered. So this is the importance of this slide. So this is how neuromuscular agents are used and not used for rapid sequence intubation. Drugs that can be used for rapid sequence intubation can be etomidate as induction agent, propofol, ketamine, fentanyl, midazolam. The doses of these drugs are mentioned here, onset of action and duration of action. These drugs can be used according to the availability of the drug, or they can be used according to the condition of the patient. And for depolarizing paralytic agents, if we are using, we can go for we go for succinylcholine. The dose is 1.5 milligram per kg. If we are using non-depolarizing paralytic agents, then we can use rocuronium or vecuronium. So these are the agents that can be used for rapid sequence intubation. For pre-oxygenation, we should pre-oxygenate the patient with 100% for 3 to 5 minutes to extend the safe apnea time of the patient. And spontaneously breathing patient, if we are pre-oxygenating spontaneously breathing patient, then we can use non-breather rebreather mask, or we can use nasal cannula. Or in case of apnea or gasping, or patient is not breathing properly, then we should always go for bag and mask ventilation. So first of all, proper position of the patient. So we have already discussed about the endpoints of the position. So we should always keep check those endpoints in mind while positioning the patient. Then next is hold the laryngoscope. So here I would like to say we should always try and hold the laryngoscope into our non-dominant hand. So we should use non-dominant hand so that our dominant hand is free to do any kind of airway manipulation that is required, or to open the airway of the patient for laryngoscopy. So, hold of the laryngoscope can be two types. One is the classic technique, okay, using the full grip of the handles, and one is the technique where we hold the laryngoscope near the blade of the laryngoscope. So, this technique, the control is better compared to the classic technique. But for the hold of the laryngoscope, again, I would like to say we can use any technique that we are comfortable with, but we should use something which we are well versed with, rather than experimenting. So you can use any technique you want to use, you are comfortable with. First of now the after positioning and laryngoscope, we need to open the airway of the patient. We can use this scissor technique to open the airway of the patient. So this is the thumb and this is the finger, and we are opening the mouth of the patient, crisscrossing. How to introduce the laryngoscope inside the mouth? Always go through the right angle of the mouth of the patient. Never introduce the laryngoscope in between. So always go from an angle. So gently introduce the blade of the laryngoscope through right angle of the mouth, and while going inside, keep on looking at the structures that you want to identify, and keep on deviating the tongue from your sight of vision. So after the complete insertion of the blade is slowly advanced deeper into the pharynx, and the tongue is gently displaced to the left side of the patient. So as we have discussed the blade insertion, so never go in between the mouth, always use the angle of the mouth to introduce the laryngoscope. So we have already we know already that what we need to identify. Hello? We already know what we need to identify when we identify the structures, and lift the handle of the laryngoscope, and we should always use our shoulders to lift the laryngoscope rather than using the wrist. Try to avoid the pressure on the teeth of the patient. And for the cricoid pressure, I would say in the older RSI technique, the cricoid pressure was used, but now it is said that using a cricoid pressure distorts the anatomy of the airway, and it makes the identification of structures difficult. So usually we try to avoid the cricoid pressure. So engage the blade into the vallecula in case of the older children and adult, or in case of smaller children, lift the epiglottis directly. So this is how we are lifting the epiglottis. As soon as we lift the epiglottis, we'll be able to see these two glistening white structures and this glottic opening. So this is how we do the laryngoscopy of the patient, and this is the insertion of the endotracheal tube. So endotracheal tube, here we are using a stellate for introduction. So you can use the slit for introduction, or we can introduce the tube directly, depending upon the situation and on the conditions. So how to check the correct placement of the endotracheal tube? So once we have intubated, attach the circuit or the ambu bag or the ventilatory other circuit. So we should always ventilate the patient, and we should see for bilateral chest rise with each ventilation. And on auscultation, there should be equal air entry bilaterally. And on auscultation on abdomen, no breath sound should be audible on the abdomen. Oxygenation on the monitor should be more than uh, SpO2 should be more than 90%, and capnograph showing the waveform for the capnograph we'll see in the next slide. So when we attach the capnography, proper waveform should be there. And if we are using a chest X-ray for confirmation, then tube should be 3 centimeter above the carina. So this is the waveform of the capnograph. So it is showing the proper waveform which we need to see when we have intubated the patient. So we should be able to achieve this waveform. This waveform will tell this your tube is at proper position. And if we are using the chest X-ray, then the tip of the endotracheal tube should be 3 centimeter above the level of carina. So we can use LMA also, just sometimes we are not able to negotiate a tube. So in that scenarios, we can use laryngeal mask airway. Laryngeal mask airway is now one of the essential part in difficult intubation, difficult airway. So for using the laryngeal mask airway, first of all, we should deflate the dorsal surface of the laryngeal mask airway. We should deflate it, we should lubricate it properly, and then hold the laryngeal mask airway into the pen holding fashion, and open the mouth of the patient, introduce the laryngeal mask airway, and slide the laryngeal mask airway along the hard palate and roof of the mouth of the patient, and advance of the laryngeal mask airway. The laryngeal mask airway will sit on the airway of the patient. It will not go inside the glottic opening, rather it will sit on the airway of the patient. And then we should inflate the cuff. When we have inflated the cuff, then there is a slight movement of the laryngeal mask airway outward, which also indicates towards the proper positioning of the laryngeal mask airway. So after inflating, there should be a slightward outward movement. And uh, for other assessment, we can again use the chest rise of the patient, bilateral air entry of the patient. Now, these are the endotracheal tube. Once we have intubated, we need to secure the endotracheal tube at its plate. So we can use dynaplast. So this is how we should take a dynaplast and slit it. This is the securing of the endotracheal tube. We can secure the tube from this end to the upper lip, to the from maxilla to mandible, or from mandible to maxilla. So we can use any technique, but the tube should be properly secured so that it doesn't come out. So this is again for securing the endotracheal tube. Securing the endotracheal tube, we can use these techniques to secure. And since we have discussed about laryngoscopy intubation of the patient, so there are certain complications that can be faced. These complications are like hypoxemia, bradycardia, hypotension, hypertension, laryngospasm, bronchospasm. These two complications are very easy. That's why we should be ready with steroids and other airway relaxant mechanism. Then there can be trauma to mouth, there or larynx or vocal cord. Then esophageal intubation, we can introduce the tube inside the esophagus, happens at lots of time. It can lead to perforation also, tracheal perforation if we are using a too much force. Then it can lead to emesis, leading to aspiration and cardiac arrest. So acute deterioration post intubation can be because of So rule out DOPE for this. D is for displacement or misplacement of the endotracheal tube or obstruction of the endotracheal tube, or there can be a pneumothorax of the in the patient, or there can be equipment failure or ventilator failure. So these are the conditions in which we can face acute deterioration. The common pitfalls of these procedures can be because of the rocking movement of the laryngoscope. So properly holding the laryngoscope, and more than holding, we should know how to lift the laryngoscope. It is very important, which comes by practice. Then inability to visualize the glottic opening, because sometimes we miss. In case of smaller children, it is very common to miss the glottic opening. Sometimes we insert too deep, or sometimes there is improper positioning of the patient, and sometimes we introduce the endotracheal tube such deep that only the right side of the lung is being ventilated, left side there is no ventilation, or sometimes we have to take multiple attempts because we are not able to do the laryngoscopy and intubation of the patient. So we keep on taking attempts of the patient. So we shouldn't do that actually. And we should always try to keep the attempts within less than 3 in 20 to 30 seconds. So before intubating this procedure, or before intubating any other procedure, the most important thing is checklist. So we should always make a checklist of all the equipments, and before attempting for any procedure, we should always check the equipment according to this checklist. So in COVID-19, the scenario is a bit different. Why? Because we need personal protection. So we should have always adequate personal protection equipments with us. So when we are doing a procedure, तो हमें करना है, हमें करना है, नहीं करना है. In case of COVID scenarios, always experienced person should attempt the procedures. It will decrease the complication, it will decrease the duration, and it will decrease the exposure. And we should always avoid.
Sorry disturbing.
हाँ जी sir.
Hello.
हाँ जी sir.
Sorry disturbing, but there is a request for a repeat of last 2 slides.
Last 2 slides, sir. Common pitfalls and deterioration. Okay.
Yeah.
Once we have intubated the patient, then we can face deterioration post intubation. This deterioration, how we can rule out? We should rule out DOPE. This is a simple mnemonic to remember. So for D, we should check the displacement or misplacement of the tube. या फिर अगर हमारी ट्यूब जो है वो ऑब्स्ट्रक्ट हो गई है, सिक्रीशंस होती है एयरवे में, so there can be an obstruction. Then pneumothorax can be there. Then equipment failure can be there कि जहाँ पे आपने पेशेंट को इंट्यूबेट करके वेंटिलेटर पे लगाया है, those ventilators are not working. So these are the things which we should rule out in case of acute deterioration of the patient intervention के बाद में. And then हमेशा there can be common pitfalls of the procedures. Like if we are causes of these pitfalls can be like we are doing laryngoscopy and there is a rocking movement of laryngoscope. So proper laryngoscopy, if we are not able to achieve, we won't be able to intubate the patient. Holding a laryngoscope and lifting a laryngoscope in itself is a technique which requires practice. So we should always try to practice whenever we get the opportunity. And sometimes we are not able to visualize the glottic opening, and this happens in smaller children lots of time, because when we do the laryngoscopy, we go beyond the glottic opening. Airway is small, equipment is small, kid is small, so we should always do the laryngoscopy step by step so that we do not miss the glottic opening. And sometimes most of the time a airway which is not difficult appears to be difficult. Why? Because we haven't done the proper positioning of the patient. And if we are doing proper positioning of the patient, we have aligned the airway, proper extension is there, then it becomes very easy to align the airway of the patient and to do the laryngoscopy and intubation of the patient. Sometimes what we do intubation into the right mainstream endotracheal intubation. We introduce the tube, endotracheal tube, we go very deep. So when we go deep, then only right side of the lung will be ventilated. Left side of the lung, no ventilation will be there. And we should keep the attempts low, and we should always have a checklist for the equipments before attempting any procedure, be it laryngoscopy or intubation or any other procedure. And in case of COVID-19, avoid awake intubation. Protection should be there. Experienced person should perform. Inflate the cuff of endotracheal tube once it is inserted before bag and mask ventilation. Use of inline suction catheters for doing suctioning. So don't open the circuit, use inline catheters for suctioning. These are the innovations through which visualizations become very easy. This is the video laryngoscope, which can be used for intubation of the patient. And the take-home message for this presentation will be pediatric intubation is an important skill in the management of critically ill children. Knowledge of relevant anatomy is important, and appropriate equipment should be kept ready at all times in PICU. Medications are an important component during intubation. Stepwise insertion technique should be performed for optimal success. Post-intubation care is essential part of intubation process. Complications should be anticipated early and should be treated early. So thank you, sir. This is my presentation.
So nice presentation. Really very clean and very crisp. Slides are very good. And I really thank you on behalf of the management and the participants as well. So thank you so much, Dr. Kavita.
Thank you, sir.
I think you're welcome.
Thank you, sir.
So any questions, anyone? You're welcome. Any questions? So there is a compliment, Dr. Ankur Saxena, from behalf of all, a very nice presentation.
Thank you, sir.
Thank you. Thank you so much.
Thank you.
Now you can stop your presentation. Thank you so much. Thank you, sir. Thank you so much. I think we have intubated the child. Some indications are there, and Dr. Yashwant Rao, very well known, our own Dr. Yashwant Rao is raring to go. Are you there?
Yes, sir, I am here.
Good afternoon, most welcome.
Good afternoon, sir.
And I think you are raring to go with your slides and to start the ventilation of this child and how
Just give me, sir, 1 minute.
Definitely. Why not? We can
Actually,
wait.
I was just busy with the meeting with the commissioner, sir. He was taking the round of pediatric COVID.
I know. You are a busy person, but thank you for extracting out some time. And really. All the participants and anyone else other than Professor Yashwant Rao, please put off your microphones.
Okay, sir. Should we start?
Yeah, definitely. So we are now starting this intubated child onto invasive mechanical ventilation in initial settings, and we'll see the problems crop up or the needs are changing of the baby, and Dr. Yashwant Rao will trail us through with this journey. Dr. Yashwant Rao, please.
Yes. Thank you, Siddharth, sir. You are my teacher, and I'm happy to give some presentation in front of my teacher.
No. Your thank yous are relate to Professor Chandkanta and Professor Shailivasti ma'am, and I thank them for allowing me to moderate, and I'm really honored to be a moderator when you are there.
Yes, sir. Should I start?
Please go ahead, please.
Yeah. So basically, whenever the child is coming to our side, we have to give the simple paracetamol for the fever. Then if child is developing hypoxemia, means ki oxygen is going below 95, 94, then we should give the oxygen plus supportive measure. And if on oxygen by mask not maintaining, then we used to use NRBM. And if on NRBM patient is not able to maintain the oxygen, then we used to BiPAP. And if on BiPAP patient is not comfortable, not maintaining saturation, then we have to go intubate the patient, and we should start the invasive mechanical ventilation. So friends, before going to the ventilation, we should know what are the initial settings, and according to the lab parameter, and according to the patient's condition and their physiological vital, we should upgrade or downgrade, or we should wean or we should update the ventilators. Next. Yeah. Oh, I'm going to present the case in front of you all. A 10-year-old male obese patient with fever for 5 days and myalgia is for 5 days. Nowadays, friends, any patient with fever, myalgia, URI, take it first as COVID, then think other diagnosis. So RT-PCR was positive for this child, and that patient there was having breathing difficulty and coughing for 3 days. Started on oxygen at home, which I was telling you, progressive worsening, then admitted to the hospital. Oxygen FiO2 was increased, and child gradually shifted to the NIV, that is non-invasive ventilation, in which either HFNC or BiPAP support is available with us. Increase in oxygen requirement and FiO2 increased to 80%. Friends, even we and our teacher used to teach us, don't increase the FiO2 above 60. Try to keep the FiO2 below 60. Don't be happy कि FiO2 100 पे saturation हमारा 96 आ रहा है. No, this is not good. FiO2 should be below 60. We should increase the support. So on NIV, patient supports up 12 PIP and 8 is PEEP. SpO2 was 80%, SpO2 was maintaining, but FiO2 increased to 80%. What were the vitals? Friends, this is very, very important. Whatever we are teaching or giving training with the support, with the PPT, actually we used to count the ABG. रिजल्ट उसका 4 घंटे 5 घंटे में आता है. EBCBC CRPAR सरकारी में रिजल्ट हमेशा 6-8 घंटे बाद आता है. तो बेसिकली वी शुड फोकस आवरसेल्फ ऑन क्लिनिकल पैरामीटर. तो ये 10 साल का पेशेंट है, स्लिपी है. कायदे से अगर पेशेंट अगर हमारा सही है तो स्लिपी नहीं होगा. तो मेरे दिमाग में आएगा स्लिपी है, इट मीन्स की CO2 नार्कोसिस हो रही है. अपीयर टायर्ड, थका हुआ है, चेहरे पे ग्लो नहीं है, हार्ट रेट 135. 10 साल का है, हम उसका हार्ट रेट अराउंड 90-100 सोचते हैं, उसका 135 है. मतलब हार्ट हैज टू वर्क हार्ड फॉर ऑक्सीजनेशन. रेस्पिरेटरी रेट 50. Friends, 50 is this child is very much tachypneic, tachycardia, sleepy, tired. This all showing that NIV ventilation is not working. That is insufficient for that child. And you see, chest movement is shallow. Bilateral crepitations are present. FiO2 80 कर लिया, तब भी maintain नहीं कर रहा है. Pulse oximeter पे 89-90. We should not be happy with 89-90. It should be 93. And whenever the child used to drink some water, saturation suddenly falls to 80%. Friends, एक बात मैं आपको बताना चाहता हूँ, प्रैक्टिकल अनुभव. अगर बच्चा पानी पी रहा है और सैचुरेशन 93 से 92, 90, 88, 87 ग्रेजुअली नीचे आ रहा है, इट मीन्स कि उसका लंग्स फिर भी ठीक है. लेकिन एकदम से हटाते ही सैचुरेशन बड़ी रैपिडली फॉल कर रहा है, इट मीन्स कि देयर लंग्स आर वेरी बैड. Patient has not been able to eat anything since 1 day. Next, अब हम क्या करेंगे? तो अगर हम इसी पे इसका FiO2 80 से 100 कर देते हैं तो क्या होगा? एक मतलब 6-8 घंटे में पेशेंट थक जाएगा, फिर वो अरेस्ट में जाएगा. उसके बाद अगर हम उसको इंट्यूबेट करके वेंटिलेट भी करेंगे तो कोई फायदा नहीं. ऐसे बच्चे को तो इंट्यूबेट ही नहीं करना चाहिए. तो वी शुड नो व्हेन टू इंट्यूबेट बाय द क्लिनिकल पैरामीटर, बाय द SpO2, बाय द वाइटल्स. So friends, we are going to start the invasive ventilation. So we should know what things we should know about the ventilator. One is the mode, second is the respiratory rate, third is the volume or pressure. Because at our place ventilators are 2 types, either volume control or pressure control. Fourth is inspiratory time, and next is FiO2, and the last we will discuss the PEEP. So which mode is the best mode? Basically, nowadays in ventilators, 8 to 10 modes are coming. basic modes were 3 initially, and they were the CMB mode, that is controlled mandatory ventilation CMB mode. Second was ACMB, that is assisted control mode, and third was SIMB, synchronized intermittent mandatory ventilation. अब हम एक एग्जांपल लेते हैं इसको समझने के लिए. सपोज हमने पेशेंट का, हमारा पेशेंट है 10 साल का, हम इसका फ्रीक्वेंसी रखेंगे 15, तो मतलब 1 मिनट में 15 चौके 60, 4 मिनट की एक साइकिल होगी. हमने इसकी अगर फ्रीक्वेंसी 15 सेट कर दी तो कंट्रोल्ड मैंडेटरी वेंटिलेशन में हर 4 सेकंड पे वेंटिलेटर एक ब्रेथ डिलीवर करेगा. इस दौरान अगर पेशेंट अपना ब्रेथ ले रहा है तो वो सिंक्रोनाइज नहीं होगा. हो सकता है पेशेंट एक्सपायर कर रहा हो अपनी सांस और वेंटिलेटर इंस्पायर कर दिया, तो फ्रेंड एकदम से सर्किट में प्रेशर बहुत हाई होगा और न्यूमोथोरैक्स हो सकता है, स्पॉन्टेनियस सबक्यूटेनियस एम्फाइसेमा हो सकता है, न्यूमोथोरैक्स हो सकता है, न्यूमोपेरिकार्डियम हो सकता है. तो सीएमबी का नुकसान ये है कि ये पेशेंट की ब्रेथ को नहीं देखता है. ये हर 4 सेकंड पे, अगर हमने 20 पे सेट कर दिया फ्रीक्वेंसी, तो 3 सेकंड, हर 3 सेकंड पे ये ब्रेथ देगा ही देगा, चाहे पेशेंट के साथ कोई प्रॉब्लम हो या ना हो. सेकेंड इज ACMB. तो सपोज अगर हमने 15 फ्रीक्वेंसी सेट की तो हर 4 सेकंड पे एक ब्रेथ देगा. मतलब सेट फ्रीक्वेंसी 15 है तो ये 15 ब्रेथ को तो सपोर्ट करेगा ही करेगा. इसकी खास बात यह है कि ये पेशेंट्स के सारे ब्रेथ को सपोर्ट करेगा जितने वॉल्यूम या प्रेशर पे हमने इसको रखा है. तो मान लो अगर हमने 15 की फ्रीक्वेंसी रखी और पेशेंट 15 बार सांस ले रहा है स्पॉन्टेनियस, तो 30 की हो गई. तो ये ACMB 30 ब्रेथ को पूरा सपोर्ट कर रहा है. इससे प्रॉब्लम क्या आती है फ्रेंड्स? इससे प्रॉब्लम आती है हाइपर वेंटिलेशन की, और ड्यू टू हाइपर वेंटिलेशन CO2 वॉश आउट होगा, इससे हमारा ABG डिस्टर्ब हो जाएगा. तो ACMB भी हम बहुत ज़्यादा यूज नहीं करते हैं. हम जो यूज करते हैं वो है SIMB मोड. और भी बहुत सारे हैं, PRVC है, तो हम उसके डिटेल में नहीं जाएंगे. सबसे इम्पॉर्टेंट और अच्छा और ईजीएस्ट मोड है SIMB मोड. जिनको बहुत ज़्यादा जानना है वो आगे बात कर सकते हैं, बट सबके लिए, हम सबके लिए सही चीज़ है कि हम एक कॉमन प्लेटफॉर्म पे काम करें, एंड दैट इज SIMB मोड, जिसके बारे में सब लोग जानते हैं, सब लोग सीख के आए हैं. दैट इज, इसकी खास बात क्या है कि हमने अगर 15 फ्रिक्वेंसी सेट की तो ये पेशेंट की 15 ब्रेथ को सिंक्रोनाइज करके सपोर्ट करेगा, बाकी ब्रेथ को सपोर्ट नहीं करेगा. तो इससे जो हाइपर वेंटिलेशन की प्रॉब्लम है वो हमारी नहीं होती. तो हमने चूज किया मोड में SIMB मोड. आई थिंक एवरीबॉडी मस्ट बी एग्री. सेकेंड थिंग है कि हम प्रेशर लिमिटेड रखें या वॉल्यूम लिमिटेड. प्रेशर लिमिटेड क्या होता है, वॉल्यूम लिमिटेड क्या होता है, ये आता है जब आप मोड डालते हैं तो आपने SIMB सेलेक्ट किया, उसके बाद तुरंत वेंटिलेटर पे आएगा कि प्रेशर लिमिटेड और वॉल्यूम. अब हम कैसे सोचेंगे? बेसिकली नियोनेट में हम लोग क्या करते हैं, प्रेशर लिमिटेड रखते हैं. 16, 17, 18, 19, 20 का PIP हम सेट कर देते हैं. तो ये हो गया प्रेशर लिमिटेड. बड़े बच्चों में भी हम कर सकते हैं प्रेशर लिमिटेड. तो हम 18-20 का, एक 18-20 सेंटीमीटर ऑफ वाटर का हमने एक प्रेशर लिमिट कर दिया. इसका मतलब क्या हुआ कि जब वेंटिलेटर ब्रेथ देगा तो सर्किट में प्रेशर बढ़ेगा. जब प्रेशर 18 पे पहुंच जाएगा तो वेंटिलेटर ब्रेथ देना बंद कर देगा, दैट इज लिमिट हो जाएगा. तो हमने प्रेशर की लिमिट 18 सेट कर दी, उतने में जितना वॉल्यूम जाएगा, बाकी रुक जाएगा. दूसरा है फ्रेंड्स वॉल्यूम लिमिटेड. वॉल्यूम लिमिटेड आप सबको पता है कि टाइडल वॉल्यूम जो हमारा होता है 6 to 8 ml पर kg होता है. तो हमारा बच्चा 30 किलो का है, तो 3 छक्के 18, 180 ml हमने वॉल्यूम लिमिट कर दिया. मतलब जब भी हम SIMB पे वॉल्यूम लिमिट डालेंगे तो जब 180 ml पेशेंट्स के लंग को डिलीवर हो जाएगा तो वेंटिलेटर रुक जाएगा सांस देना, यहाँ से अब एक्सपिरेशन स्टार्ट होगा. तो लिमिट का मतलब यह है. तो प्रेशर लिमिट बेसिकली हम नियोनेट में रखते हैं और वॉल्यूम लिमिट हम पीडियाट्रिक पेशेंट या एडल्ट पेशेंट में रखते हैं. यूज द मोड विथ विच यू आर फेमिलियर, वी ऑलरेडी हैव डिस्कस. तो हमने मान लीजिए बड़ा बच्चा है तो हमने SIMB पे रख दिया. हम वॉल्यूम पे रखते हैं, मान लीजिए हमने प्रेशर लिमिट पे रख दिया, हमने प्रेशर लिमिट 20 का रख दिया. ठीक है. खास बात क्या है कि इफ वॉल्यूम मोड इज यूज्ड, मतलब मान लीजिए हमने 180 ml SIMB वॉल्यूम सेट कर दिया, तो मॉनिटर द पीक प्रेशर, ये बहुत इंपॉर्टेंट पार्ट है। वाई, मान लीजिए लंग्स बड़े खराब हैं, लंग्स बड़े खराब हैं, तो ड्यूरिंग इंस्पिरेशन, जब वेंटिलेटर इंस्पायर कराएगा तो सर्किट में प्रेशर बहुत हाई होगा, और जब भी प्रेशर 30-32 से ऊपर जाता है तो न्यूमोथोरैक्स या वॉल्यूम ट्रामा होगा लंग्स को, ये और ज़्यादा डेंजरस हो जाएगा। तो जब भी हम वॉल्यूम मोड यूज करते हैं तो हम वेंटिलेटर पे देखते हैं कि उतना वॉल्यूम डिलीवर करने के लिए सर्किट में कितना प्रेशर जनरेट हो रहा है। या अगर हम प्रेशर मोड यूज कर रहे हैं, तो मान लीजिए हमने प्रेशर मोड यूज किया और प्रेशर मोड हमने डाला 20, तो हम ये एक्सपेक्ट करते हैं कि 20 पे जो वॉल्यूम डिलीवर हो इट शुड बी अराउंड 180 ml। अगर 6 ml पर केजी से कम वॉल्यूम अगर आ रहा है, इट मीन्स कि लंग्स हमारे बड़े खराब हैं, तो हम प्रेशर और बढ़ाएंगे। नेक्स्ट, तो वी हैव डिस्कस्ड कि व्हाट इज वेंटिलेटरी मोड। होप दिस इज क्लियर टू एवरीबॉडी। अभी तक हम लोगों ने ये पढ़ा कि हम SIMB मोड यूज करेंगे, न्यू बॉर्न में प्रेशर लिमिट रखेंगे, बड़े बच्चों में वॉल्यूम लिमिट या प्रेशर लिमिट रख सकते हैं। Now, coming to next parameter is the respiratory rate. रेस्पिरेटरी रेट की खास बात क्या है कि न्यू बॉर्न में रेस्पिरेटरी रेट नॉर्मल कितना होता है 40 to 60, तो हम स्टार्ट करते हैं 40 से, अप टू 1 ईयर 25 हो गया, 1 to 5 ईयर 20 के आसपास रखते हैं, 5 to 12 ईयर ये सब रटने की जरूरत नहीं है फ्रेंड्स, ये बेसिकली फिजियोलॉजिकल रेट है जितने से हम स्टार्ट करते हैं। जरूरत पड़ने पे ABG देखते हुए हम इसके रेट को बढ़ा सकते हैं, कम कर सकते हैं। बट न्यू बॉर्न में 12 का रेस्पिरेटरी रेट रखना बेवकूफ़ी है। इट मीन्स कि ही डोंट रिक्वायर वेंटिलेशन। बड़े पेशेंट में आपने अगर 40 रख दिया तो भी गलत है, CO2 रिटेंशन हो जाएगा। तो बेसिकली छोटे बच्चों में, न्यू बॉर्न में या छोटे बच्चों में रेस्पिरेटरी रेट ज़्यादा रखते हैं, बड़ों में रेस्पिरेटरी रेट लोअर साइड में रखते हैं। नेक्स्ट, टाइडल वॉल्यूम और इंस्पिरेटरी प्रेशर। वी हैव ऑलरेडी डिस्कस्ड कि टाइडल वॉल्यूम, तो हियर अगर हम अपने पेशेंट पे जाएं तो इसको हाइपोक्सीमिया हो रहा था कि पानी पीते ही 80% हो जा रहा था, नहीं तो 88-89, तो हमने वॉल्यूम 6 ml पर kg 180 ml रख दिया। प्रेशर हमने रखा 20 से 22 सेंटीमीटर ऑफ वाटर, हमने 20 पे रखा। व्हाट डू यू वांट टू अचीव, हम इससे क्या चाहते हैं, हमने इस पर रख के उसको वेंटिलेट करना शुरू कर दिया। तो हम लोगों ने अभी पढ़ा था कि अगर हम वॉल्यूम मोड पे रखेंगे तो वेंटिलेटर पे सेटिंग पे आप जाएंगे, पैरामीटर्स पे, तो उस पे आ जाएगा कि कितना प्रेशर राइज हो रहा है इतना वॉल्यूम को डिलीवर करने के लिए। तो ये लिखा हुआ है कि वॉल्यूम लिमिटेड पीक प्रेशर नॉट मोर देन 32 सेंटीमीटर ऑफ वाटर। अगर 180 ml वॉल्यूम देने के लिए पीक प्रेशर हमारा 35-40 जा रहा है, इट मीन्स कि हम उसको मारने जा रहे हैं, वी आर गोइंग टू डेवलप न्यूमोथोरैक्स, ही विल डाई। नो, और भी तरीके हैं उसके वॉल्यूम को इंप्रूव कराने के लिए, वो आगे हम लोग डिस्कस करेंगे। अगर हमने प्रेशर लिमिट रखा है तो वॉल्यूम, मान लीजिए हमने 20 का प्रेशर रखा है, तो हम सर्किट पे देखेंगे पैरामीटर्स में, तो वॉल्यूम शुड बी अराउंड 180-170, नॉट लेस देन 170 ऑफ कोर्स, एंड नॉट मोर देन 240। नेक्स्ट, नाउ तो वी हैव डिस्कस्ड की मोड SIMB मोड, और उसमें हमने वॉल्यूम कंट्रोल पे रख लिया, प्रेशर कंट्रोल पे रख लिया। रेस्पिरेटरी रेट चूंकि बच्चा हमारा 10 साल का है तो हमने 18-19 के आसपास रख लिया। नाउ कमिंग टू इंस्पिरेटरी टाइम। फ्रेंड्स, बड़ा इंपॉर्टेंट है कि व्हाट इज इंस्पिरेटरी टाइम एंड व्हाट इज एक्सपिरेटरी टाइम। इंस्पिरेटरी टाइम होता है कि कितनी देर में हमने इंस्पायर कराया, देन एक पॉज आता है एंड देन एक्सपिरेशन स्टार्ट होता है। तो अगर हमने फ्रिक्वेंसी हमने 20 की रखी है इस बच्चे में, तो 3 सेकंड की हमारी एक साइकिल हुई रेस्पिरेशन की। तो अगर हमने 1 सेकंड का आई रखा, मतलब इंस्पिरेटरी टाइम रखा, तो 2 सेकंड का हमारा एक्सपिरेटरी टाइम हो जाएगा। तो हम यही रखते हैं। तो अपने बच्चे में हमने आई जो है, TI जो है, हम 1 मिनट का रखेंगे, 1 सेकंड का, तो अपने आप हमारा ई जो है 2 सेकंड का हो जाएगा। इसी तरीके से अगर हमने आई को और कम किया, मतलब 0.8 सेकंड किया, तो ई हमारा और ज़्यादा बढ़ जाएगा, वो हो जाएगा 2.2 सेकंड का। तो आई-ई रेशियो हम 1:2 to 3 रखते हैं इनिशियल सेटिंग में, एंड अकॉर्डिंग टू ABG एंड ETCO2 हम इसको चेंज करते रहते हैं। यंगर द चाइल्ड शॉर्टर द आई टाइम। अभी हम लोगों ने डिस्कस किया था कि न्यू बॉर्न में रेस्पिरेटरी रेट 40 होता है नॉर्मली, मतलब 40, तो 60 से अगर हम डिवाइड करें तो 1.5 सेकंड की एक साइकिल हुई। अगर हमने 1 सेकंड इसका टीआई रख दिया तो ई हमारा 0.5 हुआ, तो ये इन्वर्स हो जाएगा। इन्वर्स होगा तो क्या होगा, CO2 रिटेंशन होगा। तो हमें यहाँ पे आई कम रखना है। तो बेसिकली जितना ज़्यादा रेस्पिरेटरी रेट का बच्चा या जितना छोटा बच्चा होगा उसमें आई हमें उतना ही कम रखना पड़ेगा ताकि एक्सप्रेशन के लिए टाइम मिल सके। आपको बस यहाँ पे ये याद रखना है कि हमें केवल आई सेट करना है, ई अपने आप सेट हो जाएगा। और ऐसे सेट रखना है कि जब आप आई वाले बटन को दबाएंगे तो स्क्रीन पे आ जाएगा आई ई रेशियो एंड इट शुड बी 1:2:3। नेक्स्ट, तो वी हैव डिस्कस्ड मोड, रेट, वॉल्यूम और प्रेशर मोड, प्रेशर लिमिटेड, IE रेशियो। नाउ कमिंग टू द FiO2। फ्रेंड्स, FiO2 ये आपके ऊपर डिपेंड करता है, हम यहाँ से पढ़ा नहीं सकते। आपकी इमरजेंसी में कोई बच्चा आता है 10 साल का और बिल्कुल हाइपॉक्सीमिक है, मतलब बिल्कुल भी नहीं मिल रहा है, तो हम उसमें 50, 60, 70 कोई गाइडलाइन नहीं है, हम तो 100 से स्टार्ट करेंगे। तो दे हैव आल्सो रिटन कि FiO2 50 to 100% से स्टार्ट करिए और धीरे धीरे हम उसको टाइट्रेट करेंगे अकॉर्डिंग टू SpO2। एंड फ्रेंड्स, ड्यूरिंग कोविड पीरियड हमें टारगेट SpO2 शुड नॉट बी केप्ट 9900 बिकॉज PO2 कुड बी वेरी हाई। तो बेसिकली हम SpO2 रखते हैं 92 to 93, परमिसिबल है। हमें 95 से ऊपर जाने के लिए FiO2 और वेंटिलेटर की सेटिंग को बढ़ाने की जरूरत नहीं है। नेक्स्ट इज पीप, एंड this is very important parameter is PEEP। बेसिकली पीप हम जो करते हैं, बेसिकली हम स्टार्ट करते हैं एटलीस्ट 8 से 8 सेंटीमीटर ऑफ वाटर से स्टार्ट करते हैं बिकॉज कोविड, वी आर टॉकिंग अबाउट कोविड। कोविड निमोनिया बाइलेटरल सब प्लूरल निमोनिया स्टार्ट होती है और ARDS बहुत जल्दी डेवलप होता है। चाइल्ड डेवलप हाइपॉक्सीमिया, तो हम पीप जो है थोड़ा हाइयर साइड में रखते हैं। वी शुड स्टार्ट विथ 7-8 पीप एंड ग्रेजुअली वी कैन इंक्रीज और डिक्रीज द पीप अकॉर्डिंग टू द पैरामीटर, लैब पैरामीटर और पेशेंट्स क्लिनिकल कंडीशन। पीप करता क्या है, व्हाट द पीप इज डूइंग। बेसिकली जैसे एक गुब्बारा है, गुब्बारे को हम जब फुलाते हैं और गुब्बारे को हम छोड़ दें तो फुस से हवा पूरी निकल जाती है और बिल्कुल पिचक जाता है। कोविड टाइम में हमारा लंग्स भी एक ऐसे ही गुब्बारे जैसा हो जाता है जो एक्सप्रेशन के टाइम में पूरा कोलैप्स कर जाता है। तो एट द एंड ऑफ एक्सप्रेशन टू प्रिवेंट द कोलैप्स हमें पीप रखना पड़ता है। तो नॉर्मली पीप हमें 3-4 का पीप इज सफिशिएंट, बट कोविड में लॉस ऑफ सर्फेक्टेंट हो जाता है, ARDS डेवलप हो जाता है, तो हमें पीप 7-8 से कम नहीं रख सकते, अदरवाइज लंग सारी कोलैप्स कर जाएंगी। और फिर दोबारा इंस्पिरेशन के लिए हमें ज़्यादा से ज़्यादा इंस्पिरेटरी प्रेशर बढ़ाना पड़ेगा जो कि लंग्स में ट्रॉमा करेगा। तो पीप करता क्या है, पीप जितने भी हमारी एल्वेलाई कोलैप्स पड़ी है या पार्शियल कोलैप्स पड़ी है, इन सबको डिस्टेंड करा देता है। सेम वे जैसे अगर बच्चे को निमोनिया आता है तो ग्रंट करता है, वो ग्रंट नहीं करता है, वो ग्लॉटिस को क्लोज करता है टू प्रिवेंट कोलैप्स ऑफ द एल्वेलाई, और जहां कोलैप्स होने स्टार्ट होती है वो तुरंत इंस्पायर कर लेता है। जैसे गुब्बारे को हम शुरू में पहला ब्रेथ जो देते हैं बहुत हाई प्रेशर का होता है, बट सब्सिक्वेंट ब्रेथ बहुत ही आराम से हो जाता है, गुब्बारा फूलता जाता है। तो हमें अपने लंग्स को शुरू के प्रेशर पे ले आना है जो कि लोअर इनसफिशिएंट प्रेशर कहलाता है, और वहां से हमारा कंप्लायंट लंग स्टार्ट होता है जो कि कम प्रेशर पे ही ज़्यादा वॉल्यूम डिलीवर हो जाता है। तो ये रिक्रूट करता है एल्वेलाई को, तो हमारी ऑक्सीजन रिक्वायरमेंट कम हो जाती है, और लंग्स को ये बेटर कंप्लायंट पार्ट में रखता है ताकि कम प्रेशर पे ही हम ज़्यादा वॉल्यूम डिलीवर कर सकें। दूसरा, जब पीप रहेगा तो एल्वेलाई कोलैप्स नहीं होगी, तो ये एटिलेक्टिको ट्रामा को भी रोकता है। बट अगर आपने पीप ज़्यादा बढ़ा दिया तो क्या होगा, लंग्स का प्रेशर बढ़ जाएगा, तो कार्डियक जो रिटर्न है सुपीरियर वेना केवा इंफीरियर वो कम हो जाएगा, तो हाइपोटेंशन होगा, शॉक में जा सकता है, तो हमें इसको बचाना है। दूसरा, जब ज़्यादा प्रेशर बढ़ा देंगे तो बैरो ट्रामा स्टार्ट हो जाएगा। ट्रिगर सेटिंग बेसिकली 3 तरह की होती है। वन इज फ्लो ट्रिगर लिमिट, मतलब बेसिकली जो हमारी लिमिट होती है, वन इज वॉल्यूम लिमिट, सेकंड इज प्रेशर लिमिट। तो इसके लिए सर्किट में जो हमारा स्पॉन्टेनियस ब्रीदिंग होती है, इसको वेंटिलेटर सपोर्ट करेगा कि नहीं करेगा, इसके लिए हम लगाते हैं ट्रिगर सेंसिटिविटी, कि जब भी सर्किट में नेगेटिव प्रेशर जनरेट होगा या नेगेटिव फ्लो जनरेट होगा, वेंटिलेटर इसको सेंस करेगा कि पेशेंट अपनी सांस ले रहा है, तो वेंटिलेटर अपनी मैंडेटरी सांस को छोड़ के अगर SIMB मोड पे है, पेशेंट की ब्रेथ को टेकअप कर लेगा, उसको सपोर्ट करेगा। इससे फाइटिंग नहीं होगी वेंटिलेटर और पेशेंट में। तो ये ट्रिगर है। तो हम बेसिकली ट्रिगर 2 से 4 के बीच में रखते हैं और फ्लो ट्रिगर चूज करते हैं। दूसरा होता है प्रेशर।
Dr. Yashwant, your voice. Dr. Yashwant, are you saying something? Your voice is not audible at this point of time. Hello, Dr. Yashwant, you're not audible. You're finished with your presentation? Hello, Dr. Yashwant. Shall I go to the next one?
बस हो गया.
Okay.
Hello.
ठीक है. Actually, I am attending another meeting as well. So now Dr. Yashwant has kindly, started the ventilation, has led us through to various stages, and now the child is all right. Are we ready to wean it off? Or still? There is one question. Let me see what question is there. Okay. Someone was saying about you, the voice is on, but you have perhaps stopped abruptly. So perhaps someone said that you might be saying something. Are there any questions for Dr. Yashwant?
Any question, please?
So that means they have understood all very well. Now I invite Dr. Anubha Srivastav from Prayagraj MLMNC, and she will be talking about weaning and extubation. You're welcome.
Good afternoon, sir. Thank you, sir. So should I start?
Yes, Anubha, you can start. Good evening.
Good afternoon, sir. Good afternoon. So all throughout the day we have learned about, I'll just start.
Hello, you're not audible.
I'm not speaking yet. I'm just opening my presentation, sir. Start. So I hope my screen is visible now. Hello. Am I audible now?
You are very well audible. Your slides are gleaming. Please go ahead.
Yes. Okay. So all throughout the day, we have learned about how to initiate ventilation, how to go about and bring about the changes in ventilatory setting. So no work is complete until we have weaned the child and extubated the child of the ventilator. So I'll be discussing about weaning and extubation. So mechanical ventilation is no doubt the key step in management. But apart from that, the discontinuation of support at proper time and in a proper method is also equally important. So we'll be dealing the understanding the goals of weaning and what's the physiology behind them, and how to test. Actually, before weaning and extubation, we should test whether the child is ready for it or not, and learn the actual process of weaning and extubation. So these are the general headings under which I'll be discussing. So the two topics that I'll be taking is weaning and extubation. So weaning is transition from the ventilatory support that we have been giving so that the child tides through his pathology. And when his pathology starts resolving, we gradually
withdraw the support, and that is weaning. Extubation, as the name suggests, is the actual process of removal of the endotracheal tube. So if you see the journey of mechanical ventilation, you can see that the weaning takes as much as time as the ventilation. So in fact, on an average, weaning accounts for approximately 40% of the total duration of mechanical ventilation. So we need to give equal importance to weaning and understand the concepts. Once we decide on weaning the child, bringing down his support, then we should first assess the roadblocks that he have against spontaneous breathing and his own capacity. So the I'm sorry. So the respiratory loads against which the patient breathes may be his lung conditions like low compliance or increase in dead space, or his cardiovascular may not be well supported, or he may have chest wall disease. And to fight against these, he needs to have a good neural drive. The neuromuscular should be working well. So we have to find out the perfect balance before we actually start weaning. So in fact, understanding the balance will help us determine when the ventilatory assistance is no longer needed. So we have the mechanical ventilation phase. So that can be pre-weaning, and then we start weaning, bringing down the support. And before extubation, we give a spontaneous breathing trial, and then finally extubate the baby. So what are the basic requirements when we start weaning? So on any settings that we have put, if the child is maintaining well, then we have to assess whether his oxygenation is well and there is no buildup of carbon dioxide. Apart from that, what is very important from pediatrics point of view is that for weaning and bringing down the ventilatory support, it is not only the lung, good working lung that we require. In fact, all the other major organs should also be working at their optimal functioning. Otherwise, a weaning or extubation may fail. So we should ensure that other major organs are also working well, and the local airway protective mechanisms are intact, so that the child doesn't have to be re-intubated. So if the child is having a saturation of oxygen around 60 millimeter of mercury, at low FiO2 as low as 40%, with PEEP of a very low PEEP of 5 centimeter of water, and is maintaining good vitals, age appropriate respiratory rate, is no buildup of carbon dioxide. Carbon dioxide is at around 35 to 40. The dead space has come down, dead space ventilation has come down, and his cardiovascular, temperatures, electrolytes, nutrition, renal, liver, GIT, in fact, all the major organs, if they are working well, temperature is maintained, then only we can think about withdrawing the support. Because if any one of this is not working and we start withdrawing the respiratory support, the patient may again crash. So at local level, local level, he should have an intact airway protective mechanism. He should be conscious with good cough reflex and gag reflex, so that he doesn't drown on his own secretions. So weaning can be of two types. The modern method is the rapid method, and there is a slow traditional method. So it basically it depends on the pathology for which the child was actually ventilated. If it is a short-lasting pathology like shock without multi-organ affection, a post-operative stabilization, or ventilation done only to wait for as long as the seizure stopped, then we can go for a rapid weaning. But conditions like multi-organ failure, cardiac failure, prolonged shock, they may require prolonged weaning. So traditional approach is no doubt a cautious approach to avoid failed extubations, because they increase mortality, morbidity, and hence the cost of treatment. Modern approach has been adopted because many of the times we have seen that pediatric patients go for self extubations and they do not require intubation. So why not better give a planned extubation? So yesterday we had learned about the modes of, today only we learned about the modes of ventilation. So in ventilatory, out of these modes only, for weaning, we can go for SIMV mode, the pressure support mode, or the simple TPs. As you can see in this graph, they were shown earlier also to you. In SIMV, the bigger wave, the loops are of the machine driven breaths, and the shorter ones are the one that the patient has where he has his own efforts. And in pressure support, all the breaths are supported by the machine. And TP weaning is like providing a constant CPAP. So in SIMV, the patient's respiratory muscles would work during spontaneous breathing, and during the rest of the time, there will be the mandatory beds will be supporting his parameters, and in between he may have his spontaneous breath. So what we do while using SIMV as weaning mode is we gradually, in steps of 1 or 2 breaths per minute, we decrease the mandatory breaths and let the patient's breathing take over. And in present ventilators, we have pressure support combined with SIMV. So in that case, the breaths that the patient is taking spontaneously, they too can be supported with pressures. While using pressure support as a weaning method, here what happens, as we have already learned, the inpatient support, all the breaths are patient triggered and they are flow cycle pressure limited. So what we do, we gradually reduce the level of support. So all his spontaneous breath, suppose we have been giving a certain level of support. So as the patient improves and he's maintaining normal vitals, respiratory rate, tidal volume, then we can gradually decrease the amount of support that we are giving to each breath. And when the pressure is reduced to as low as 5 centimeter of water, so we can very well conclude that pressure level is not enough to contribute significantly to ventilatory support, and thus he can overcome the work imposed by ventilator system and can have a spontaneous breathing. In TPs, here you can see how a TPs looks like. So it is like a constant CPAP. So what we do, we attach this to a ventilator and set the ventilatory mode to spontaneous or CPAP. The advantage of attaching a ventilator is that we get the advantage of alarms. So if there is a apnea, so our ventilator will alert us out. So it is similar like providing a small amount of pressure support, and gradually we monitor if the child is able to breathe on its own with this little support, then we can plan for extubation also. So extubation is the actual removal of the endotracheal tube. So the first and foremost thing that we need to give value when we are planning extubation is the primary indication for which the patient was intubated. Has it resolved or not? If it was pneumonia, has it started resolving? If it is shock, has it is the patient off inotropes and the patient is able to maintain a stable airway? So that is the point when you can decide if the child has come down to the minimum pressure, minimum support on ventilatory setting, then he's properly weaned. And then if you think that the child is now ready for his spontaneous breathing, then we can plan for extubation. So again, we have to decide what's the right time for extubation, because early extubations can lead to failure of extubation, leading to reintubation and increased mortality. And a delay in extubation will definitely prolong your ICU stay. There may be other complications adding on, and again that may cause an increase in mortality. So before we actually extubate the child, we need to give a spontaneous breathing trial. So it can be given with a TPs or CPAP when the pressure support is as low as 5 centimeter of water. So what we do, we give a spontaneous trial, let the child breathe on its own with a TPs there and endotracheal tube there. We may start with as low as 30 minutes, and gradually we increase the duration of spontaneous breathing. So it helps us to assess whether the child is ready for extubation. So with as the child sustains smaller durations of spontaneous breathing, we can gradually increase the length of spontaneous breathing trial. And important thing is that we should not overdo it. We should give periods of rest in between the trials, and we should avoid doing these trials at night when the floor is manned by less people. It is better to do it in morning and evening shifts. So once you put the child on spontaneous breathing trial, you can objectively and subjectively assess whether the child is sustaining well on these spontaneous breaths. So if he has tachypnea, tachycardia, hypotension, or neoacidosis, so it means the child is not doing pretty well on spontaneous, and he needs to be again put back on ventilatory support, even though on minimum. Sorry. If otherwise, you can also see for increased anxiety, increased effort, agitation. So all these again point out these are subjective criteria for assessing whether the child is having a good spontaneous breathing trial or not. So if you find these things, it's better to keep the child on ventilatory support, even though on the minimum settings. So again, when the child, once you have given these spontaneous breathing trial, the child is doing well. So again, look at its vitals, his heart rate, respiratory rate, the blood pressures, if they are in the normal range, and the child has a minimum pressure support, a PEEP as low as 5 with pressure support as low as 10. And if is maintaining saturation says FiO2 around or less than 40, so then you can decide that the child can be extubated. One thing important before actually extubating, is look for endotracheal tube cuff leak, because what is very common in pediatric is the laryngeal edema once in intubated patients. So before extubating, you bring your ear close to the child's mouth and try to hear. If you are able to hear any leaking sound, that means there is still some space between endotracheal tube and the laryngeal pathway. So there are less chances of edema, the tracheal laryngeal edema. So a sound of leak gives you an indication that the child may be ready for extubation. And if you are not hearing it, then probably there is some kind of edema that may further hamper extubation. So once you have checked all these things, decided to extubate, you should stop feed 6 hours prior to actually extubating, and definitely stop sedation 2 hours prior to extubation, because you don't want a sedated child extubated who has a less of neuromuscular drive, and then again he may be requiring ventilatory support. So there are various predictors where to see whether these extubation will be successful or not, but none of these parameters are infallible in predicting. So you are the best judge. Even we have extubation checklist. You can put down your notes and assess whether the child is ready for extubation. But definitely the treating clinician is the best judge. These are only helping parameters. So how
there is a question for you.
Sorry?
There is a question for you if you wish to answer in between, how to appreciate the leak and how to...
Yeah, I would like to take the questions in the end if it's not
okay. Okay, please go ahead. Yeah.
Okay. So so once we decide decide on extubating the child, so first thing that we need to do is we should stop or taper the sedation. So if the child is on longer acting sedatives, we can put him on shorter acting ones, and then assess the consciousness and muscle power. So you can, if the child is old enough, you can ask him to do some, you can see whether he's following commands, responding to those or not. Or in younger child, you can see for the grip of child, or if the child is kicking his limbs. So that will help you assess the neuromuscular power of the child, and whether you should see that there is no pooling of secretions. So so as we are discussing for assessing peritubal leak, so if the child is on cuff tube, so you deflate and you listen. So what you can hear the sound, when you put if it is a uncuffed tube, if you put a higher pressure, you just put momentarily on a higher pressure, or you can do this with your ambu bag also. So if you are pushing some pressure, then you may hear the air coming out. So that will help you assess the peritubal leak. So So if the child is already for extubation, so you decrease the ventilatory support. Sorry. Okay. Yeah, and although these positions are more appropriate for little older children, so you need to explain the procedure to the patient, put the patient in proper position, and before actually extubation, pre-oxygenate the patient with 100% oxygen. Suction the patient's mouth and pharynx and re-oxygenate after suction. So you clear the pathway as much as possible. Then you squeeze in the resuscitation bag. So what happens? The secretions will be forced in also just at the time of withdrawing the ET tube. You when you push in the resuscitation bag, so this it will be almost as good as inspiration. So there will be maximum abduction of the vocal cords, and that's the time you can pull out the endotracheal tube. So after once the patient have been extubated, so you put the child on same FiO2 as before extubation. You monitor the patient and encourage coughing and deep breathing, and listen to breath sound, auscultate, and especially in the neck area, because you want to hear for any blockage of passage due to edema. And monitoring even after extubation is very important, especially the next 1 hour is very critical. And if possible, although not required always, you may do a arterial blood gas measurement to confirm the patient's oxygenation and ventilatory status. So this is put in a algorithm in a flow chart, whatever we have discussed till now. So extubation is successful if you don't need ventilatory support even 48 hours following extubation. However, if the child does not sustain spontaneous breathing trial or requires re-intubation, or we lose the child within 48 hours following extubation, then it is a failure of extubation. So what can be the causes of extubation failure? So it may be the abnormalities on respiratory mechanics. So the parameters were not judged well before, or there had been prolonged duration of mechanical ventilation. So the child has become dependent on ventilation. As I pointed out, other organs may not be working well, so there may be hemodynamic instability, the consciousness may not be up to mark, and the secretions, the child doesn't have reflexes, well enough reflexes to manage his own secretion. So these are basically the main causes of failed extubation. Apart from there may be remote causes like genetic, metabolic causes, and most importantly the baseline pathology for which the child was intubated and ventilated, that must have been resolved. So a short note on tracheostomy, when it becomes apparent that the patient requires prolonged ventilatory assistance, so it's better to put in a tracheostomy tube. However, however, it should be performed only after initial period of stabilization on ventilator, and when you think that the patient may need a long time ventilatory support. So there is a scoring to assess the peritube. Somebody's mic is on. So this will assess the post extubation. This is for assessing the post extubation striders. So again, apart from this scoring, you need to keep a clinical vigil. So since we have talked so much on post extubation airway obstruction, a small word on it. So it's more common in patients who are of younger age and in whom a larger ET tube has been used, and who had multiple attempts of extubations and airway manipulation, and who haven't been given adequate sedation during ventilation. So so there may be some asynchrony or repeated struggle that had led to edema and hence airway obstruction. So there's a small there's role for steroid, but it has been seen that it does not significantly introduces the reintubation rate. However, it reduces the incidence of post-extubation stridor. So you may give dexamethasone 0.15 to 5.5 milligram per kg, and you can give around 3 to 4 doses, but it should be given preferably 12 to 24 hours before actual extubation. So post-extubation, you may require simple mask or prongs if the child is stable, but for child with higher risk of failure, you may need to put him again on non-invasive ventilation. You need to give a longer monitoring of around 24 to 48 hours and look for airway obstruction, respiratory distress. And because everything is connected, respiratory increased work of breathing may lead to hemodynamic instability. So you also need to have a watch on his hemodynamic parameters. So non-invasive ventilation after extubation appears to be beneficial in very sick patients because it improves survivals and lowers the mortality, and also reduces the risk of nosocomial pneumonia due to repeated intubations, and hence shortens the ICU and hospital stay. So apart from this airway obstruction, there are other complications for extubation that we come across. So there may be transient increase in blood pressure and heart rate lasting for a short duration of 5 to 15 minutes. So that's why the first hour of monitoring is so very important. And there may be incidences of laryngeal spasm and laryngeal edema, few incidences of hemorrhage or trauma to vocal cords. So you need to be very careful while extubation and take utmost care. So to end the talk, I would like to just point out some take-home messages. That a goal for weaning from mechanical ventilation is to gradually decrease the support, and so that he has ultimately an independent breathing. So your clinical judgment is the best. Before extubation, it's better to give spontaneous breathing trial. SIMB, PSV, and TPs are the common weaning modes. And obstruction, post-extubation airway obstruction is the most common cause of extubation failure, and use of steroids may help to prevent these. So these are my references, and I would like to thank all the contributors. Thank you. So now we can take the questions, sir.
Yeah.
Yeah.
So I think there was a question about leak. So I think you have already answered that question.
Yeah.
But
So we need to push in a bit of air with the pressure, and then that the air that escapes, that will give a short sound. So we have to hear for it.
Then there is another question.
Yes.
Would you like also to assess diaphragmatic indices before extubation?
So as I told you, there are, I showed you a few of things. So there are the number of parameters that may help us to assess whether extubation will be successful or not. But the bottom line is the clinician who is actually seeing the patient, his assessment, clinical assessment is given the most priority. So you are best. So you can use this, I think, you can use these scoring systems and parameters, but of course, if you're seeing the child is well enough, neuromuscularly doing well, so you can very well go for extubation.
Then there is an open question for all. Anyone wants to answer? Do we use CAV mode in children? I think CAV is continuous airway ventilation mode in children. I don't know. We haven't been having this mode in our this thing, but is there anyone who would like to answer, or otherwise we will get more information and can answer this question the other day, that is tomorrow. CAV mode in children. Dr. Soumya Saxena is asking. Dr. Soumya, if you know something about, please enlighten us. Perhaps it is a continuous airway air volume mode in children, sort of. CAV. I haven't come across.
Yeah, neither have we ever used it.
So, Dr. Soumya, do you know the answer? Please, you can answer this question in case you know. Or she wants to say something else. So there is no response. Perhaps she has left already, or what? but I have asked, no, she has said no, sir. Okay, we'll try to sort out the answer. Is it, have you written right and am I spelling right? CAV, mode of ventilation in children, Dr. Soumya, please answer, yes or no? Okay, I will try to find out and try to get some answer and try to answer it tomorrow. So that's all from today. I think me along with others perhaps, end up with the wise end. And thanks to all elegant speakers and wonderful slides. I apologize for some snags in between, but the speaker took all these things in stride and definitely she managed. So taking leave from all. So should we leave? Calling off the day. Thank you. And Dr. Ankur Saxena says excellent presentation, ma'am. Same from me. Thanks to the organizers. Thank you, Professor Shelly Avasti, ma'am. Thank you, Chankanta, ma'am. We call it a day, and tomorrow will be another excellent day and good topics. Thank you. Dr. Namita, so Mamtamik and all, and Dr. Sio, Sindhu, to your team, thank you for today. Call it off. Please give me an invitation for tomorrow's as well. I would like to attend.